already done, so we don't have scope of the middle
So we
finger
are left
anyway.
with this finger only then.
Navin, how would you know that how many people are joining or they are going to?
I am getting message from the web person. I will announce in between.
Okay.
Start just now to tell you that in the both the webinar, the pre-webinar click in hip it is 1890, and in the knee that has reached to 1560.
Very good.
Okay, great.
It is changing every minute, so I will tell you at that time. Just now, it is around 2000 has reached almost. People have seen the where they are going to travel. They know the destination now.
Yes, good.
Good.
So I think you should be like Narendra Modi, just to start dot at 11, like he started his lecture at 10, right? And everybody was just watching at the.
I'll be giving a small introduction, just introduction of the webinar, and thanks from the Dr. Karthik is with me. He is our treasurer of Gujarat Orthopedic Association.
Karthik,
And
just raise your head.
he is there. He is the treasurer. He is the treasurer of Gujarat Orthopedic Association. And evening at 4, I think Dr. Kamlesh Dev Murari will join with me to welcome you all on behalf of the Gujarat Orthopedic
20
Association.
minutes.
All right.
Great.
15 minutes. Please.
Navin, just speak about that Zydus Ostivia.
Yes. It will come. Once I will
It's on the
show the
banner.
website, it will come automatically.
Okay, you
It's
can
11, so we can start.
I-
sir.
No. Just a minute. Let me complete the technical work. Otherwise, they will
Okay.
not be able to see. We are talking, but they are not able to see it. Once I will generate the key and put there, then they will be see. It is recorded just now. Recordings they will see.
It will not make any difference in our screen.
It will not make any difference in your screen. And don't open what they are saying in the website. Otherwise, that will echo. See, already echo started from my computer. From my computer, it has started already. Let me stop from my computer. Just a minute, huh? देखो अभी जो स्क्रीन आ गई उसमें अवतार जी ने पहली उंगली ऊंची की हुई है
पहले वाली स्क्रीन होगी.
हाँ पहले वाली स्क्रीन है वो नेचुरली इट टेक्स एज अ थंबनेल फर्स्ट स्क्रीन it takes the first screen as a thumbnail. So now we are on air. Let me start to share. I'm sharing. Okay. I welcome you all faculty on behalf of Gujarat Orthopedic Association, and myself and Dr. Karthik Patel as the treasurer of Gujarat Orthopedic Association are here to welcome you, and we are very much thankful to Dr. Deepak Bhai for making this possible, collecting the cases and coordinating everything, and we are thankful to all faculties, senior faculties, and we are thankful to delegates. Daily they are coming online and seeing the webinar in 5,000 to 6,000 numbers. For the delegates, those who have joined recently, this is the link for recordings. If you want to see the recordings, just click this link. And as you go down in the screen, there is a red button. Here you are seeing the live webinar of today, right? Now as you go down, there is a screen of Slido where you can put your question and just click the button send if you want to ask the question to the faculty. It will come to me and I will throw this question to the faculty. And if you don't want to text it, just record your audio or a video in a WhatsApp and click this button to WhatsApp me. So let me introduce the faculty. Dr. Deepak Dave is a very senior arthroplasty surgeon at Ahmedabad. He will be moderating the whole session. Dr. Pachore sir, everybody knows him. Dr. Harish Bende from Mumbai. Dr. Anup Jurani from Jaipur. So he will open up his treasure of his knowledge and his share. Dr. Dimple B. Parekh He's a well-known arthroplasty surgeon at Ahmedabad. Dr. Avtar Singh, he's doing a lot of work at Amritsar. So we'll have that experience from the Punjab also. We have a Dr. Kartik Sukla, but he has not joined. He's somewhere busy. He will join meanwhile. Dr. Parin Kantesharia from the Rajkot. He will be sharing his experience. Dr. Sanjay Dar is from Mumbai. Dr. Atish Sharma is from Ahmedabad, and Kartik Patel, one of our EC member of Gujarat Orthopedic Association from Ahmedabad, is joining. Let me say that this educational activity is supported by unrestricted grant from the Bone Max PTH makers Zydus Ostiva. And here Dr. Deepak V. Dave was instrumental to make them to contribute to the Gujarat Orthopedic Association. So Deepak Bhai or Dr. Harish Bende, whosoever wants to start the screen, they can start it. Deepak Bhai, you can take over for introduction and then Harish Bhai can start it.
Yeah,
Can you hear me, sir?
Yeah, I think you have already given introduction. My sincere gratitude to
Now, Kartik Sukla is also joined from the mobile, I think.
senior
Welcome, Kartik Bhai.
senior faculties. As all you know, a father figure for all of us, Dr. Pachore, for the hip arthroplasty, is a man whom everybody respects and sees as a teacher. Plus, we have Dr. Harish Bende, Dr. Sanjay, Dr. Avtar, and Dr. Anup Jurani. So from all across Pine India, and few of our colleagues, Dimple, Dr. Pareen, Atit, and both Kartiks, they are from Gujarat. So we have a quite a good combination of senior and young faculties from across the India. We want to make it interactive. Every faculty has,
Harish Bhai, you start sharing. You start sharing so that we can save the time. Yeah.
every faculty has put lot of efforts to select the case, and we have tried to see that we cover all the subjects of hip replacement. So the cases are not likely to repeat it, and we will get a proper message. So each faculty has selected a different subject so that we can get knowledge on different things. And I invite Dr. Harish Bende, senior arthroplasty surgeon from Mumbai, to start with his first case.
Okay, okay.
पचोरे सर मोबाइल बंद रखना प्लीज
मैं साइलेंट में डाल दिया.
किसी को जवाब मत दो प्लीज.
Okay, so we start with this
The
opening
mobile
case.
is silent.
These are the cases of a THR to be done in a deformed hip. Now, this is a patient, 32-year-old male, had a transthoracic fracture neck femur, came to a surgeon as a fresh injury seen within 12 hours. So normally our plan should be, we probably would like to fix it because a young patient and we wouldn't like to sacrifice the head and do any kind of replacement surgery. Question is, should we do open surgery or closed surgery? Should we fix with screw or a plate and a screw or anything else? So the surgeon eventually decided that he should fix like this. So he did fix with a single screw and a DHS, and he did a valgus osteotomy subtrochanteric to improve the compression at the fracture site. And this is an acceptable way of doing it. The only problem is when you do this amount of valgus osteotomy, although you have made the fracture line more horizontal and more conducive for healing of the fracture, you have also increased the
stop your
vertical
ringing.
forces.
Stop your mobiles, please.
So basically what happened is, in this situation, fracture may heal, but many times the vertical force which is there, which will eventually cause a problem with the healing of a bone and avascularity. So the bone gradually started healing with significant amount of collapse, and then that patient had significant gradually increasing pain. So this has practically healed, but if you see later on, because of pain, the implant were removed, but there was a significant portion of a head which developed avascular necrosis, and patient continued to become limping and painful. So this is how the patient came to us. Now question is, we have to give him a solution with so much amount of head which is gone and collapsed. We have to replace the hip. Now, what difficulties do you expect if you want to do a replacement on this patient? And I'm quite sure all of you will see a lot of patients like this, where something has been done previously, either for a fracture or by a surgeon osteotomy, and the proximal femur is deformed. So if you analyze the problem, this is the AP picture. And if you see the axis of the medullary shaft, it is actually exiting almost in the center of the head because of the valgus osteotomy. That is the reason you have to enter the hip and the medullary cavity after taking the neck cut at this point along this line. The commonest error is the surgeon tries to enter the hip from the conventional point at the level of the base of the trochanteric tip, that is the piriformis fossa. And if you do that, your reaming will be coming quite obliquely and you may end up fracturing medially or creating a shaft rupture in the medial part. If you look at the X-ray intra pictures, that is the reason we open the medullary cavity from almost to the center of a head to get access to the cavity of the femoral shaft. Now, if you see the lateral X-ray, again, there was a deformity of a lateral X-ray, but fortunately not very severe. Sometime in these valgus osteotomy, there is inadvertent anterior or posterior angulation, which is added to the osteotomy without surgeon realizing, because most of the time surgeons just look at the AP X-ray and they miss the lateral angulation. This patient had some amount of lateral angulation, more of a translation. So if you look at this shaft cavity and look at the head, how it is there, the shaft is shifted posteriorly. And that is the reason if you want to enter the shaft again, your entry point has to be quite significantly posterior. If you go by the center of the cut neck of the femur, you will end up going into an oblique direction and then you will again perforate either posteriorly while reaming or broaching with your broach and reamer. So it is very essential that during the surgery, you take this point which you are analyzed from the X-ray during the table. So on the table, when we are actually doing the surgery, you can see that the entry point of my broaching was almost back to the posterior cortex. And this is where we can get properly into the shaft without causing any fracture. So if this is the neck, you can see that my entry point and eventual implant was almost touching the posterior cortex. Now, many times the problem is if you go for a standard size an implant, you may not get adequate position because in spite of taking all this care of shifting the entry point, you still are having a very narrowed canal, and in which situation you may have to use a smaller implant. So in this particular patient, we went for a smaller implant and we could get away with the smallest possible stem. Imagine if I had tried to go for a bigger stem, then we would not have been able to negotiate, and then the option would have been to do a recorrective osteotomy at a subtrochanteric level. But by analyzing the case before surgery, by knowing exactly the entry point for broaching and reaming, we could get away with a simple solution rather than trying to do a complex operation of trying to do osteotomy and getting a more complex space. So in nutshell, you must see the extent of deformity in both planes, AP and lateral, if you get a proximally deformed femoral bone while doing THR. Then we must assess whether we need to do a osteotomy at the time of THR. And if we have to do osteotomy because deformity is too big and we cannot accommodate by using a smaller implant, then you have to plan whether it's a 2-stage or a 1-stage surgery. But as I said many times, if you plan the case well, a simple solution with smaller implant can avoid a complex operation. Thank you. Any questions we have? Any? Yes, Dr. Pasore.
Thank you, Harish bhai. Well condition. Can I
Yes,
go ahead?
Dr. Pasore. Yeah.
Can I go ahead? Hello,
Navin bhai.
Navin bhai.
Yes,
Dr.
yes,
Pasore
sir.
wants to have a question or a comment.
Can I? Navin bhai.
Yeah, go.
Yeah. Okay. Harish, you well
Yeah.
described post osteotomy patient. Very important to take a very proper lateral X-ray, and it has to be done by the surgeon because most of the technicians do not know how to get that lateral X-ray. That is number one. Number two, if you feel a displacement, I think CT is, for not this case, but in general, CT is very ideal. If 7 cuts are showing the canal open, then you don't require to re-osteotomy. This is one of the important step of the CT scan. Number two, on the table, you should have image intensifier so that you drill, and Harish described extremely well. Varus osteotomy, your entries are different. Valgus osteotomy entries are different. Extremely well described by Harish. So you need a cannulated reamer for these patients. And sometimes Harish has done good job, but sometimes you keep a SROM. Wagner cone is very ideal sometimes for these patients because you need to adjust antiversion and few other things, and that's a very very important point which he discussed. And bailout option, always keep cemented for post osteotomy because you will be able to negotiate a smaller implant and version control will be possible for you. Thank you, Harish.
Yeah, that is very right, Dr. Pachure, that when we do such surgery, we do have option of SROM implant because it's very versatile implant for these cases where the femur is deformed and you can actually have a different fixation. You can have metaphyseal fixation with the sleeve component and you can have a diaphyseal fixation with the stem component. And between the sleeve and the stem, you can plan your osteotomy to correct the deformity, whatever is there. And it is very important. And we had kept the SROM implant. Only thing is SROM is almost 1.5 times more expensive in our setup. So we always try to ask for a smallest size implant which is available. And if it is possible, then we can go ahead with a simpler surgery. And the cemented stem also has to be kept. And is absolutely very, very important point which Dr. Pachure has mentioned.
Can I ask?
Yeah, anybody else?
Yeah.
Can I ask a question?
Yeah.
So if we are doing subtrochanteric osteotomy, then only SROM will work with the keeping the femoral canal like this. SROM
Yeah.
will not work. In that situation, we'll have to use a cemented stem.
No, we have to do osteotomy at the level of the deformity.
Yeah, that's
And
what I am
once you
saying. If we are
do
doing
yeah.
osteotomy, then only we'll be able to use the SROM. Without
Yeah,
doing
that's correct.
osteotomy, we can't use
No,
the
we can't use
SROM.
SROM if you are not doing osteotomy.
Yes.
That's correct. Then we have to use the cemented stem,
Yes.
which can negotiate the smallest cemented stem will be easy. Something like a C stem or something like a Exeter type of stem,
Exeter.
which is quite narrow and we can negotiate with any deformed cavity relatively easily. That's correct.
Dr. Sanjay wants to say something and then Parin wants to say something.
Yeah, Harish, thank you for the presentation. I just wanted to know, as you go medially for a valgus osteotomy for your entry point, do you need to worry or is there any limit by which your offset is offset going
So
more medially?
in fact, if you go medially, your trochanter is shifted laterally because of the previous osteotomy, and that improves your abductor mechanism. And if the patient has limb to begin with, because patient has started with a very collapsed neck. If you see pre-op X-ray of that patient, the neck was very shortened and the patient had significant limb and a pain. The moment you get a proper neck offset of the neck, the trochanter is lateralized by the previous osteotomy, you get a much better and stronger abductor mechanism, and it's actually a boon for you because you eliminate the trochanteric limb or the abductor limb the patient had. So the patient almost get near normal movement. You don't have to worry about that.
Harish, any role of a short stem like a meta stem or something like that?
Metastem is based on a varus position and it has to have a lateral fixation on one side. It has to abut the lateral cortex and it has to rest on the medial neck. Metastem, if you try to put in a conventional wisdom, either vertical along the cavity, it sink inside. So I wouldn't like to put metastem in these deformed cases because first of all, we don't do it very regularly. And then you may not be able to place it properly. So I would not be very comfortable doing it.
Second question, proximally coated stem versus fully coated stem. So what is the preference of the faculty? Dr. Avtar, Dr. Anup, can you put a light on this? Young people, what is your choice of stem?
Yeah, so
can I answer?
Yes,
yeah, sure.
Okay, one by one, please.
Yeah.
Yes.
Yeah, so
Anup,
my stem is always a proximally coated stem, which is 2 offsets. So 2 offset options. So you can recreate the offset, but it's always proximally coated.
Avtar?
I have 2 comments about this case. Very nicely done. First comment about the fixation. We should avoid giving valgus. The more valgus we give, the more chances of avascular necrosis we get. So that was the reason for avascular necrosis of this patient. And then about the stem, proximally coated, yes, very good stems. But another good stem can be a short Wagner. If we have access to that, that will be a very easy stem to use in this patient.
Yeah, I
And
think
that will be my first choice.
Dr. Harish has already said about Wagner cone as a good option.
Yeah.
He already mentioned that. So I
Okay.
think in and all, a good lesson.
Can I throw a question? There is a question from the audience.
Yes.
Yeah. One anonymous, he has not written the name. The tip of the implant is near to the healed subtrochanteric fracture. So chances of stress rising is more. Is it not a problem?
Number one is this is a fully porous coated implant. So usually the coating and bone healing happens at a proximal level. So the line of force transmission is not the tip of the implant, but the proximal part of the implant. Second thing is a healed fracture is a very, very strong area of a bone, and it's very unlikely to cause any problem there. So in this situation, the fully porous coated, it was a coral implant, which is usually bone ingrown in a proximal part. So it doesn't cause any tip pain as it is thought many times. No, I'm not worried about that position.
Okay. And the second question is to you is, Dr. Bhende sir.
Yeah.
How you assess the proper size of the stem? Any difficulty you assess for operatively?
It's a very good question. It's extremely good question. Now, normally when we tap for or the broach for any non-cemented component, and I use a coral stem on most of the cases, we tap by putting the hammer. We have to hold the hammer head, not the handle. And you have to not hammer the broach inside, but tap the broach gradually. When you tap the broach in, as you start increasing the size, every time the broach goes in completely, you rotate the broach by holding the handle. If you have got a cavity like this and your broach does this rotation like this, that means it is loose. You keep on increasing the size till the broach stop rotating, and when you rotate the broach, your stem moves or the leg moves. That is the point of the best fit which you get. Now usually you get two best fit. For the first time you start getting the good fit and the femur is moving when you rotate the broach, you can still use a one size bigger by hammering harder. And I say that is the second best side. Now always go for the first best broach. Do your trial implant. If you feel happy, use the same one. But if you feel many times in an osteoporotic bone, the first fit which you get, you do the trial, you dislocate the trial, and you find that now that broach has become slightly loose, then you may have to go for one broach size higher up and use the next one. So I normally have to go by how the fit happens by rotating the broach in the medullary cavity when the broach is sitting to the depth what you want.
Yeah, thank
So
you, Harish.
you mean broach and femur should move one as a one piece.
That's correct.
That is the line, right?
That's correct. Absolutely
Navin
right.
bhai, we need to move to the second case now.
No issue,
Okay,
sir.
okay.
Go ahead, sir.
Very good.
Harish bhai, thank you. Excellent message.
Yeah.
Yes, I'm stopping your screen sharing.
Okay.
Or
Thank
you are going for second case or no?
No, Dr. Pachore.
Next one.
Okay, sir. Pachore sir, you start sharing. Once he has put the last slide, the next speaker can put his first slide, no issue. So that we do not have a change over time. That change over time we'll use for questions. Yes, sir. And if you can pose a problem, there is one suggestion came from the audience. If you pose a problem and then discuss with the faculty and then come to the solution by the faculty who was operated, that will be a better module.
It is not possible in all the cases. So
no, maybe wherever they want every faculty's opinion in that case, what they will do, and then ultimately what has been done.
this is not.
Can I go ahead?
Okay, sir.
Yes.
Good morning and welcome to this. And I'm very thankful to the Gujarat Orthopedic Association.
Thank you, sir.
My hospital, Shelby Hospital. I'm going to slightly give a different thought on this bilateral case. I'm going to actually, this is a straightforward case, but I want faculty to answer them rather than me doing it, because I want answers from my faculty, and they all are extremely well-trained surgeons. And they have probably better knowledge than me because they are very young now and very enthusiastic. This is a very short history. 37-year female, work as an IT engineer. A known case of ankylosing since 2007. And she's looked after by rheumatologists on various drugs. And the symptoms actually started after the age of 25 years as an important finding, which will come to it. Clinical examination, both hips are ankylosed and 10 to 15 degrees of flexion deformity and some degree of abduction deformity. The spine is completely fused from cervical to lumbar, and she has lost some lordosis. Lordosis, this is another important finding which we will discuss. Both these other limbs are right. Neurological examination, again, most of our surgeons are actually missing these patients. And it's very important for all of us to just, it takes hardly 2 or 3 minutes, which we'll discuss neurological examination. Pulsations are all right. So most of the time, ankylosing spondylitis, always there is a delayed diagnosis, and the literature says almost 8 to 18 years. And does age matter on the onset of the disease, Harish?
Yeah, I think the earlier the onset, more will be the deformities, and earlier will be the fusion, unless they get a proper treatment to prevent it by a proper rheumatologist.
Anup?
Yes, sir. I think age matters a lot, and most of the patients who present early have most severe deformities because they're not treated properly by biologicals these days. So I think it matters a lot. Yeah.
Very important, Anup, you brought it point, because if you look at the data, if patients are under the age of 15% patients will go for THR, and that's a very active, very bad disease. They don't do well. They are called juvenile ankylosing. They don't do well. And if you look at after the age of 20, there's only 1% patients will go for. This is one of the important message which from our faculty has been. Dimple, do you like to see any operative area, skin, any other part of these ankylosing patients?
Yes, definitely. I would like to see the local area as well as to see the spine also, because most of the time spine is also involved. So we need to see both the places properly.
Yes, Anup.
If the patient has got severe adduction deformity, I look very carefully at the groin. Yeah. Because these are the places they have usually ulcers and things like those. So I think
fungal infections as well.
Anybody else wants to comment? Please raise your finger.
Yeah. We need to also check the cervical spine fusion, and we have to find out whether the patient will require a fiber optic intubation, because these people cannot be obviously done by a spinal or epidural anesthesia.
We'll come to that. This is another important message for all of us, that this is the patient who landed in my clinic, and look at that patient. He has a psoriasis with ankylosing spondylitis, and the data, there are 10% of the patients who have psoriatic arthritis with ankylosing. So be careful of this group of patients. That's another important message as far as this is concerned. So don't only look at the only operative area, look at the other areas. And this is now patient bilateral ankylosed hip. This is a lady. Dimple Mai, do you want anything else? This is the case.
Yes, of course, we need a spine X-ray. That is another thing which is important.
So we need more imaging.
Yes. And if possible, CT scan also.
What about the Rajkot doctor? What is the Pareen? Anybody, anything you want to add? Okay. So you need any additional image. What are the images you need, Harish?
Well, if you can get a CT scan, we need to know exactly how much the bone mass is there, how much amount of protrusion which is there in the hip. So that will help.
Yes, we'll come to that.
And the cervical spine X-ray, X-ray to know the mobility, etc. Yeah.
Doctor, will it make any difference in a standing or sitting X-rays?
Yes, which I'll come to it.
It is a fused hip and a fused spine, so it won't make a difference.
These are just X-rays. One of the surgery is already done. You have to look at the scoliosis, Harish. Then you can adjust your, especially the abduction angle regarding what side is the. There's one important message for all of us. This is another very important, whatever the standing X-rays are. You have these patients, we will come to that, why it is important, whether the patient has got lordosis or kyphosis, because they are going to make a difference, and Anu will come back with a great, because he has read a lot on this. The cervical spine is very, very important. What Dr. Harish, whether they are in flexed or whether they are in extended, so it is very, very important to see them. So we need additional image. I agree, totally agree. Any idea, Anup, or anything? Those are very grossly deformed hips and knees both, because we can't get an X-ray and then templating properly. Any idea of getting this just a reasonable X-ray? Any technique which can be used to get a reasonable templating? May not be possible, but anybody has an idea?
Yes, so first thing is if we can do a better X-ray by taking the patient down and eliminating the knee flexion deformity.
Absolutely.
So we can take a better hip X-ray. That's one. Once we do that, we can use a marker and take a true size X-ray and use digital templating these days. It's available with most PACS software, and we can do reasonably good.
That's the video. Just get the patient down and eliminate that, and then angle your tube. Then you will be able to get some result.
They do have some pulmonary issues, and they are on the drugs, which will have some effect on ECG and echo, because they are disease-modified drug they are taking on a regular basis since long.
Yes, we will come to that extra manifestations of.
Dr. Patare,
Okay.
any role of inflammatory markers in ankylosing as a prognostic and in the future care?
Well, they already have HL and all that. They come with this diagnosis already fixed with you. Okay.
Okay.
Any medical comorbidity, Avatar, on these patients?
I have no idea about that.
Okay. Anup?
Yes, so these patients, especially women, have got more interstitial lung disease than men patients with ankylosing spondylitis. So to be very careful. While in men, we can do a bilateral, provided their lung function is good. In women, if the lung function is not great, we should do staged.
Okay. So there is one.
Is aortic stenosis a problem?
Yeah, this is the data. A lot of anterior inflammatory bowel disease, psoriatic feature, I told you, aortic insufficiency, third degree heart block, reduced pulmonary. That's why all these patients, even in younger patients, should go for echo. And these are the patients who have a high morbidity. And this is a data which is very important for us as far as the extra articular manifestations which are there. How often you see Anup ankylosed hips when this ankylosing spondylitis?
Yeah, so we see them very often. I wouldn't say it's an everyday case, but definitely we see one in 4 to 6 weeks.
Harish?
1 in about 8 to 10.
Okay.
1 in 10.
Okay, this is a small, I'd like to share our own data. This is our own classification. All of us, you know that. And roughly around 24% of patients ankylosing will come with ankylosed spine, ankylosed hips. But Anup and Harish, I'll tell you, now it is getting reduced because patients are here now. This is the data which we did it at when Dr. Dolakia was alive. Okay, so this is something which I'd like to share with you. Regarding indication, non-ankylosed hip, I think we all agree, Anup and Avatar and everybody. What about the ankylosed hips? What is your indication for ankylosed hip as these are young patients? You want to operate everyone?
Want to operate them bilateral? Was that your question?
No. Indication for ankle, not bilateral together. But that is, but ankylosed hip, suppose in functional position or something. What are your indication for ankylosed hips? Yes, Harish.
Yeah, the number one is if it is a bilaterally ankylosed hip, these patients are physically very disabled because they cannot sit, they cannot stand, they cannot walk, and it is very difficult for them. So bilateral definitely need surgery. If it is unilateral ankylosed with other hip, normal. Now that is not very likely in a case of primary ankylosing spondylitis. But suppose for some other reason, one hip is ankylosed and a spine and other hip is mobile and an ankylosis is painless, then you have to be thinking twice about offering the surgery to the patient.
Yeah. Anybody else want to add something?
In seriously stiff spines, patients with severely stiff spines also is an indication, because they generally try to follow their center of gravity, and so giving a mobile hip would be more useful.
I think usually in an ankylosed hip, there won't be much pain. So mainly, as Dr. Harish said, it's going to be the immobility and difficulty and contractures in bilateral, which is the indication.
Okay. So patients with low back, ipsilateral knee pain, contralateral hip pain, non-functional ankylosis, and to improve, sometimes limb length, I think that we cannot keep in mind. I think that's just, I have put in a theoretical answer, but that is not the answer. But improve mobility is one of the important. Now younger people today generation is totally different. So I think I agree with Harish and all of us, all of them, even though there's no pain, but you have need a mobility of this, because the same lady, they were not bad, but the problem was the functional thing was. And if you look at these x-rays, there are horrendous cases. There are gross deformities, adducted, flexion. All these patients will 100% need, 100% need. Anybody wants to comment on this? Okay. Harish told very carefully. In maybe 20 years back, we didn't have a 20-30 year fiber optic, and people have lost their patients because they could not intubate these patients. So very important that you have a fiber optic intubation for these patients. So anesthetists must see these patients preoperatively without any fail. Very, very important, important fact. So you have seen this. Anu, what is the status of the hip abductor of these patients?
Yeah, so usually you cannot assess them very accurately if it's a fused hip, but usually the abductors are well functioning. You can do an EMG and see it, but they can function because post-operatively, as patients exercise, they do gain some hip abduction. So hip abductors are functional.
Harish, you want to any comment?
Usually these people are able to walk by circumduction before surgery by shifting the pelvis forward backward. These people have usually very good abductors, and post surgery they recover all very well. We on a routine never do a EMG nerve conduction study in this patient because we don't need that.
Dhar, anyone to comment anything?
Yeah, I think it's a principle of sarcopenia because of the less use. Probably is a muscle mass also likely to go down. It's not only like we don't see osteoporosis, but something similar to what happens to the muscles also. So probably lack of exercise, lack of movements may probably reduce the muscle strength or mass.
Yeah, just to share you something, look at this MRI. This is a normal patient MRI. Look at the hip abductors. Quality of the abductors are extremely good. And if you look at the ankylosed hip and see that quality of the abductors are so poor. But there is no question that they are muscle junction, nerve muscle junction is intact, so there's nothing to worry, but they take a long time to improve because you look at the diffuse atrophy of the muscles. So all these patients are going to have a lurch for longer time. What do they expect, Anup, to take? How much time they take?
Sir, at least 6 months to a year.
Right, much more, Anup, much more. Much more. So if you look at the so look at this quality of the abductors. Look at that. There's some completely like a fatty degeneration, something like complete fatty degeneration of the abductor. So it takes time. So don't expect, you have to tell the patient that you will have a lurch for at least a year and maybe two, and gradually it will improve. That is important message as far as the hip abductors are concerned. But they are working, no require of EMG of this patient. Only require EMG NCV is already operated patient or surgical orthodesis patient. Otherwise, don't need. For a primary spontaneous fusion, you don't need. I agree with Harish. A surgical approach, Anup, what will is the surgical approach? Most of the time is approach is posterior surgeons, you all of?
Yeah.
Yes. Posterior, but we may need to go anterior in case it's a abduction deformity. So we may need to go anterior through the same incision and take the neck cut anterior and then continue posteriorly.
Excellent. This is one message I wanted to pass. Yes, go ahead. Harish, go ahead.
Yeah. These cases need an approach from both the sides. This is what was described by Dr. Ranawat when I learned with him. I call that tent approach because That is a concept which can explain the way approaches work. So depending on whether the deformity is anteriorly, internal rotated or external rotated, we can go by the normal standard incision, which is take for the posterolateral approach. We dissect the posterior flap and an anterior flap together and try to approach the neck area. And then we using a curved osteotome, we can cut the neck from front and from the back. If patient has significant interrotation, then the posterior approach will be easy to begin with, and we cut the neck and then we rotate the hip and go from the front. So we need to isolate the trochanter from the front and from the back, keeping the abductor on the trochanter and vastus lateralis intact as a single piece. So that's a anteroposterior approach which was described by Dr. Ranawat.
Yeah, okay. What Anup said, I'm thankful to Dr. Bhosle because he has landed me this mark abduction external rotation deformity. Anup, that is the time you cannot reach from behind.
That's right.
One other important finding. You look at this, beautifully done. This is just this finger is very important. Just putting just under the hip abductor. And just put the two retractor, one on the hip abductor, and open the capsule in a T-shaped manner and reposition your spikes. Very important, otherwise neurovascular damage will be there. Reposition after the capsule cut. And then look at this beautiful exposure of the neck. And then you take out the wedge of a bone as called a sandwich or whatever you call in this various technique have been described. So you'll have to take a wedge out before you can deliver the neck outside. And I'm very thankful to Bhosle. This is a wedge, he took it out and then he brought it out and he releasing now iliopsoas. So this is one Harish and both of them had described. So sometimes you might have to go on the front and back. So this is the case which was on surgical. So Anup, do you need to take out that wedge?
Yes, absolutely. That's the basic principle of in situ osteotomy, because if we take the cut too proximally, we may damage the anterior wall of acetabulum. So it's very important to take a conservative cut, then take out the wedge very carefully after we have identified the periphery of the acetabulum.
This wedge is important, Anu, because if you try to take it out, you will get a spiral fracture. So you need a space to head to come out. That is the idea of that the sandwich.
Dr. Pachore,
yes, go ahead.
Is there any suggestion which side osteotomy you should do first? Like
Which side means?
When you do the sandwich osteotomy.
Yes, do first on the head side. That is a softer bone, and then you go to the calcar area down.
Okay.
And if you are these are usually very hard bones. Sometimes you might have to, if you don't have the saw cannot go inside, you have to do multiple drilling and then use a very, very sharp osteotome or use a very thin blade because the area is not that adequate to get a bigger saw inside. Anybody wants to add anything?
No.
We go ahead?
Yeah.
Okay. Yeah. After this neck osteotomy, then this is the thing which is there. I'll just come to the reaming a little later on. But Harish, just describe how will you take this now to ream?
No, number one is when you start reaming, we have to take the proper neck cut and the trochanter can be shifted usually anteriorly or sometime posteriorly based on the
enough
position.
Exposure. Okay.
Once you have got a good exposure, you start reaming inside the neck and start reaming more and more. Normally, even if the bone, there is a bony ankylosis, you can always see the junction of the head of the femur and the edge of the acetabulum. And if you expose at the periphery, you can see that the head acetabular junction. When normally I start reaming, I use a smaller reamer, go deep within the neck, within the boundary of that acetabulum rim, which you can see, till I ream medially adequate enough. And at one point, when the reamer goes in and I can see a soft tissue, between the bone, and that is called a fat pad cell described by your group from, Bombay Hospital. And there is always a small fat pad between the head and the medial acetabular wall. Now, many times what happens, you start reaming inside, you go almost say an inch inside and you are still worried that you'll ream through and you don't know how much depth is there. The simple thing is use a small 2 mm drill bit, ream medially, and you can use the ordinary depth gauge from your trauma set and you can actually measure the amount of medial wall. The normal medial wall on the acetabulum is not more than 4 or 6 millimeter thick. Beyond that will be a couple of millimeter of your fat pad. So if you have got depth which is more than 8 or 10 millimeter, means you are still rimming inside the head of the femur. So once you see the fat pad, then you start expanding within the limits of the acetabular border. And that's how normally I like to do that.
Yeah. Anybody want to add something? Yes, Nipple Bhai.
So that has been very well described, fat pad sign. So as a beginner, if you are really in doubt, keep IITV in the theater and check it 2-3 times. It's nothing wrong in it. Unnecessary, you rim more on medially and you lose the medial wall. So on safer side, keep additional IITV and check it.
Yeah, agreed. Anup?
Yes, and in these are the cases we should not be in a hurry to put our final cup. These are the cases we put our trial cup first, put the trial stem, take the trial reduction, see the combined antiversion, and then put the final cup, unlike our routine primary case where we insert our final cup once we prepare. So I think it's very important. And in this particular case, since there is loss of lumbar lordosis, we have to decrease our antiversion to prevent more combined antiversion and anterior instability.
Avtar, you want to add anything?
No, it's the same. My view is the same. We need to take care of the fat pad sign, and then we need to take care of the inclination of the pelvis, rightly said by Dr. Jirani.
Dr.
Okay.
Pachore, can we move little fast, please?
Yes, sure. These are X-rays of this lady, one of the patient. Any critical comment, one of the Anup or somebody can do is critical comment on this. Even though it was done by me 10 years, but there are some fallacies, some problems are there.
Yeah, we don't have a pelvis X-ray here, so it's difficult to comment on the inclination, but the cup is vertical, and this is a dangerous thing for instability. So that's one.
Let me tell you, on the left side, the cup is slightly inferior. That means I have taken too much of ischial bone. So this is one of the mistakes which has happened to me. And the opposite side, I did not medialize the cup. So this is there are two mistakes. Version and things were all right, but this is the placement of the cup was not ideal. This is my own case about 10 to 15 years back, but this is the mistake which I have done it.
Would you use IITV?
Yes, once in a while, not very regularly. I agree with Dimple Bhai. If you have an access, very absolutely. This is one short video that how this is very important video. How this is rimmed. You look at this is a neck cut, because any small rimmer will not go inside. You have to gouge and take out a little bit of bone from inside. Then only you can capture the rimmer. Otherwise, the rimmer will start floating and medially, laterally, superiorly. That hard cortical bone is you need to remove with a nibbler rather than osteotome, because usually it's very, very hard. And once you are done that, then you start your rimming. And very important, watch for anterior and posterior always. This is another mistake which happens with all of us. So always put a finger, that's a finger, my finger going in posteriorly and anteriorly, and trying to see that the smallest rimmer to gradually, even though still that cortical bone is still visible, and just don't worry about it. Go on just rimming very gently, very, very cautiously. And then you will see that pad sign which all of us have described. That is the most medial wall. If there's a worry, take the depth gauge. That's a depth gauge I'm using, and that's a pad of fat. You can see the depth gauge. It's okay.
Is TAL also one of the marks?
Yes, TAL. How much, Anup, this ankylosing, do you see the TAL very clearly?
Yes, we always see the TAL, though there may be an osteophyte which we may need to remove inferiorly. Once we remove that osteophyte, we'll be able to see the transverse acetabular.
Anyhow, because of time, I don't want to go into too much of this classification, but one important message you would like to pass. A spinopelvic tilt more than 20 degrees, spine surgeon there is there. So if the realignment should be done first and the hips should be done. So one important message, pelvic tilt, especially in lordotic spine, you have to increase anteversion because the pelvis is already in the forward position. So if you, that is very important, which is seen here. forward, and in a kyphotic spine, the pelvis is already backward. So if you increase anteversion here, you will dislocate the hip anteriorly, what Anup was telling you. And this is again one of the important paper coming from Suryaban. So this is one important message. Again, lordosis, increase cup anteversion, kyphosis, reduce your cup anteversion. And this is just a lady, that IT engineer. Look at this disability of this lady. She was like a block,
Yeah, log rolling, like a log rolling.
Yes, yes. Yeah, look at that, how she was able to just lie down. Okay. And this is her after about maybe 2 years of surgery, roughly. And fair degree of gait has improved quite well. And she's able to do this up and down without any walking aid. And important in this lady is we have started doing a CT scan of all these patients and look at the parameters of, so we have not done much of anteversion, just about 25, 28 degrees. And that's important for standing and sitting x-ray, and she never dislocated. And this is one more patient in this group.
Just what?
Just one small thing now. Post-op protocol, Dimplebhai?
So, so it depends on the how much good fixation that you have achieved and post-operative X-ray. Most of the time we are able to make them stand and walk immediately, but then we have to be little careful for the dislocation point of view. It depends on the X-ray.
Yes.
Dr. Harish Bhande and Deepak Bhai both want to comment, and probably
Harish?
Dr. Avtar also.
Yeah, one comment I wanted to make about these hips is, contrary to what many people believe, the risk of dislocation in this is not higher than the normal hip. In fact, it is lesser, because many of these hip, unless you have done a wrong alignment or wrong version, but if your version alignment is right, many of the hip develop a significant amount of ossification around the hip. And then these hips are not going to dislocate as easily. So risk of dislocation is significantly less in a post-enclosing patient than compared to a say, patient following a TC fractionic femur.
Myositis versus for that, do you recommend endocap SR or any role of radiation?
Yes, so we come to that. I think early mobilization was Dimplebhai. Role of indomethacid, absolutely, there is no question. And we monitor serum creatinine. Sometimes the drugs are contraindicated. That is the time we do what is called single dose radiation. It is done actually either you can do pre-op, but most of we are doing in a post-op day second, and we do what is called 700 rad, and that is linear accelerator. It is only in the capsule, and we have to cover the shield, the implant, especially the bone ingrowth implant, so that it does not hamper the bony ingrowth. So it is a single dose 700 rad next day morning with what is called linear accelerator.
Navin Bhai.
There are questions. People are very much interested. So if you want to prolong, no worry. We have to answer their questions also.
Listen. We have already asked so many questions.
Okay. But the questions from the audience is must, sir.
No, I'm going to
Dr. Avtar.
Just one comment. We should be very, very careful about the sciatic nerve when we are exploring this hip.
Absolutely.
Yeah.
Okay.
Sir, the question is from Dr. Harpreet Gill from the Ludhiana. Cup position, should we put the anteversion in all or selected patient? Then which patient, considering that spine deformity will progress over the years? And second question is, what the size of the head done by the panelist? And the third question he has put is the role of the dual mobility cup in these patients.
Yeah, I know.
Three questions. Yeah.
Yeah, excellent.
He has already answered.
Yeah,
First
excellent
question. His question is the spine deformity progressing? Do we keep any possibility of that possibility in putting in version anywhere?
No, in these cases, the spine is already fused. But suppose it is not fused and it's a progressive fusion.
Progressive, yeah, that is the question.
Then it's very important to consider that, because once the spine fuses and the pelvic tilt changes, it's reported that the patients will dislocate anteriorly. And these are the cases where dual mobility is indicated.
Yes, that was the second question. And third question is, what is the size of the head done by the faculty? He wants the opinion of the faculty, what the size routinely they select in these cases. Is there any difference in the size selection of the head?
Size of the head will depend on the socket size, but if the socket allows a 36, which usual male patients do, then we should choose a 36, but not ceramic on ceramic, ceramic on poly in these particular cases who have altered anatomy.
Okay. The another question from a junior is how to locate the hip center. Any difficulty in locating the hip center?
Dr. Pachore is answering that.
No, you give it.
Maybe Dr. Bende can answer.
It's not very difficult to identify the hip center, because when we expose the hip, you can easily see the tap, and you are going to medialize the cup till you can get the medial fat pad sign. So technically speaking, your lower end of the cup is going to be resting on a towel somewhere nearby, and the medial part is on the fat pad, that is the lateral wall of your true acetabulum. So automatically, without doing anything, if you follow these two landmarks, you'll get a proper center of the rotation of the head. You don't need to do anything else beyond that. All you need to check is your inclination is right, and your version is what you want to do, either a standard according to the existing version, or you want to give a little more or little less based on the position of your spine and a pelvis.
Okay, the Vinay had asked the question, probably it is answered to Dr. Pachore sir. Any hip special X-rays? Vinay Parasar had asked it. I think it was cleared, I think, in the next slides, I think so. Is it so? Anything new in the hip special X-rays, sir?
Nothing.
Nothing.
Which I already told you that a standing X-ray, and especially the X-ray, lateral X-ray with standing and sitting, that's a new thing which.
And people are asking, they have difficulty in spinopelvic deformity calculation and the cup placement. That has already been discussed.
Yes.
Now the new questions have come for the previous case also to Dr. Bende also.
Yeah.
Dr. Bende, sometimes with the tent approach, very small sleeve of the abductor remains.
Yeah.
Any change in the post-op protocol in your case?
No, depending on the case, as Dr. Pachore has mentioned, in patient who has not walked for a long time, especially in a case like an excision hip, which I'll be presenting later, or ankylosis for a long duration, the abductor could be very weak and friable. You have to be extremely careful when you use the tent approach, that you have to give adequate amount of the bulk of abductor. The commonest error is the posterior part is very easy because you are going behind the abductor as you are normally used to. But the anterior flap which you use, if you take a section of a gluteus medius along with that, then you will create a very narrow abductor sleeve. So you must make sure that you go anteriorly enough and spare the entire gluteus medius and even some portion of minimus. And your anterior approach is actually in front of it. It is not a mirror image of the anterolateral approach done in a Harding's.
Yes.
See, there is a one big difference is in a Harding's approach. When you go by anterolateral approach, we are taking some portion of abductor. So this is your abductor. In a Harding, you take anterior 1/3 or even half of the anterior abductors and then take your anterior flap. Here you go entirely in front of the gluteus medius. So you have to keep the entire gluteus medius intact. Otherwise, the commonest error in this tent approach, or I call it tent because it is easy to explain, but it is described by Dr. Ranawat to begin with. So that double approach basically which is done, the commonest error is you take a very big anterior flap and go through the gluteus medius, causing a small gluteus medius which can rupture.
Dr. Pachore.
Yeah, I'll only share one important slide, which I'm going to skip other slides.
Still, Dr. Bende has one question from
Yes.
Parasar, Vinay Parasar. Still, the sir is adjusting the slides.
Yeah, I got already.
If you are using the short Wagner, does your entry point of bracing will change or not?
So the actual entry point depends on the shape of your implant. If the implant is a straight implant, or some implant are an oblong implant. Yeah.
He has specifically asked, if you choose
Yeah.
the short Wagner, will you change the point of entry for bracing or not?
No.
In a short Wagner, we still have to go along the shaft, so we have to be coaxial with the shaft. So the entry point remains more or less same.
Is there a role of any distal fitting stem in your case? Is it easier to perform safely?
No,
That is another question by Dr. Nitin.
Yeah. Distal fitting stem in these patients is a overkill. Many times people go for a bigger stem like Wagner, like a SROM, etc. We don't need a distal fitting stem. We have adequate proximal bone stock to have proximal fitting stem, and you can keep a distal shaft for the revision in case we need it in future.
Yes, Dr.
And
Thakkar, your comment on the
Dr.
results.
Vishnu has asked, after all possible release, if the GT does not come down, what next?
So, technically speaking, after the releases, GT has to come down. There is no other reason why it cannot come down. But what we normally do is we can fix that greater trochanter. Now, if you are finding it difficult, because then you have to bring the distal femur proximal. And the commonest error is if the hip is short and you are lengthening it too much so that the GT is not coming down, then you have to do subtrochanteric osteotomy to bring the proximal part little released.
Okay, in ankylosing case, there is a question that you said that the use of C-arm. Is there any role of navigation, hip navigation?
I think navigation master is sitting there. Ask Dimple Bhai. Ask Dimple Bhai. I never used it.
Yes, it is Dr. Bala Aditya who has asked.
Now, basically, the anatomy is quite distorted, so it's better to use everything. I mean, it is safer to do take the help of whatever gadgets we do have. Frankly speaking, navigation we have used in normal hips more than the deformed hips, so we don't know anything. I mean, much about it. So it is always better to use all the different things. One is a drill bit and use a depth gauge, or use of navigation as well as IITV, because once we lose the medial wall, we don't have anything.
There is one question
Yeah.
for Dr. Anup. Dr. Anup, specific question to you, Anup. What markers you use for true size X-ray templating?
Oh yeah, so the PAX software that we have, they give us the markers. So there is a chain, like a zip chain, which has got markers, and you put it in the center of the X-ray, and your PAX software reads that as equivalent to 1, and then you actually get the true image, and that same PAX software is used for digital templating. So it's
Okay,
all
Dr. Avtar wants to say
calibrated.
something.
I just want to make a comment about the use of navigation. I don't think we can use navigation in these bony ankylosis because we cannot rotate the hip, so we cannot feed the data to the navigation machine. So it's out of question.
Okay.
Pachore,
sir.
Your comment on the results, and then
Yeah, that's the last slide. This is actually a monogram paper from our own country, from Suryaban and Rajesh Malhotra. It has opened the eyes of the most of the world. Look at the data, 54 patients, they were all fused. Average age was very, very low, 25. Mean follow-up was fairly okay. And they did had a 3 patients anterior dislocated. And that's the first time he described the anterior dislocation in spite of using a posterior approach. And it was commented that there's a pelvic parameter problem. And another important thing which Suryavan described is 38% patients have some minor discomfort pain. So we must tell the patient that there is going to be some minor issues as far as the results are going to be concerned, not like other primary hips. And survival is not that great in uncemented hip because there are 2 or 3 papers coming out. So we have to worry for these young patients. So he did had a first 5 years good, but they were dropping down. I think I think it's almost 10 years back this data was. I had actually requested Rajesh Malhotra to follow up this younger group of patients and just find out what has happened after 15 to 20 years. That's another important thing which is from this paper. So I think my conclusion is ankylosed hip is a surgical challenge. Surgical orthodoxies have, those who are already surgical orthodoxies, they have poor prognosis and they are very difficult one. New spinal pelvic parameters still not very crystallized. And Dr. Harish said ankylosing, the rate of dislocation is lower side because they don't get that amount of mobility. But frankly, today I'm telling you with our quick approach and soft tissue, the people are getting almost 190 to 100 degrees, which I never saw 20 years back that amount of flexion patients are getting. So today we are putting the cups in proper version and we are getting good moments, which you saw 2 patients. So there is a chance of dislocation. And secondly, we are using indomethacid, so the calcification or ossification is very less now. Identify medial wall, which everybody described. TAL is a very, very reliable option, which every faculty was insisting. And Anup clearly mentioned trial reduction is vital. But this is not very dynamic in relation to spinopelvic, but still we must do a trial reduction for these patients. Lordotic spine, more anteversion, kyphotic, less anteversion. That's one dictum we have to take home. Prophylaxis for ectopic ossification, whatever you want. And if you do all technical, I think the results are gratifying. And I'm thankful to all the faculty and especially GOA to organize such a fantastic program. Thank you.
Dr.
Thank you,
Pachore.
sir.
I think
Thank
it
you,
was
sir. Thank you, sir.
very comprehensive lesson on the ankylosed hip. We all have lots of interesting cases. Move forward
Yes.
to Dr. Anup Jurani now for
Yes.
instability issues.
Just for your interest, now we have touched to 3259. Visitors are clicking.
Okay.
3259.
Thank you. Yes, Anup.
Anup, don't show everything.
Yes. No, I'm not sure. Yeah, it is just okay.
Yeah.
So instability is something all hip surgeons really fear, and classical instability has been described for 22 heads or 28 heads when it used to be more, and that instability has decreased with better understanding of combined anteversion used of 32 and 36 heads. But simultaneously, other challenges of instability are rising because we're doing more complex cases. We are seeing long-term follow-ups. So we need to understand instability with current paradigm and see what are the possible solutions in 2020. So let's look at the first case. It's kind of counterintuitive, but we need to look at this in great detail before we jump to a conclusion. So this was a 50-year male patient dislocating 7 years post-surgery. So he had an acetabular fracture 9 years back. After 2 years, he had a total hip. And 7 years post-total hip, he started dislocating, and he was perfectly all right in those 7 years, never had a single dislocation. Now, we should really scratch our minds as to why this is happening after 7 years, what's gone wrong. There is no infection, serology is normal, and we need to look carefully before we start planning. Now, he has become a recurrent dislocator. So he has dislocated 7 times in last 6 months. So as soon as he sits, hip dislocates, then somebody puts it back and it again dislocates. So what's going on here? We can see the plates are there. And let me take a question maybe to Dr. Pachore, who is the most experienced. Dr. Pachore, what do you think is going on? 7 years post-surgery, he's become a recurrent dislocator.
At this age, at 50, but if you are the patient is started with 60, 65, and next 10 years, the rate of the Mayo Clinic has described, your Dan has described, as 10 years increasing the age, the rate of dislocation 2 to 3% more, because soft tissue get lax. The problem is the medical comorbidity come down. All these factors are there. So that's the data coming from Mayo Clinic, but not at the 50. They're usually after 60, 65.
Yeah, that's soft tissue laxity coming later in age, abductor deficiency. But what do you think is going on in this case?
The possibility of you'll have to think of 7 years is the wear, because what poly was and the wear, the superior part of the superior posterior wear, that is the poly, which is probably bothering you, and that is allowing to dislocate this. There is a possibility.
Now, Dr. Bhende, how important is it to look at the old implant stickers? And if you don't have the old implant stickers, what do you see in this particular X-ray that will give us a clue?
So the number one is, as Dr. Pachore has mentioned, if the hip is stable for 7 years, that means there is probably no orientation issues with the hip.
That's
the Virgin extra must be right.
That's
the reason which can come up after 5 to 7 years is only wear in a poly, which is causing loss of a posterior wall and making the implant dislocate. Now, one thing you can look for if you've got an implant stickers is what type of poly they have used. Number two, what type of metal, whether they have metal head or a ceramic head, because metal head have a higher risk of having osteolysis at an early age by 5 to 7 years. So if these two things are there, you may get some clue. The second thing is you can look at the immediate post-op X-ray and a current X-ray in a reduced position to see the peripheral distance between the periphery of your acetabulum and a periphery of your cup. So that can give you some idea about the where, if it has happened. If there is an eccentric position of a reduced hair, reduced head, then that means there is a poly issue, probably a wear or maybe a fracture, and that is the reason for your dislocation.
So Dimple, are you there, Dimple?
Yes, I am.
Yeah, all right. So Dr. Pachore and Dr. Bhende described these two important things. before you plan this surgery and go in, would you like to keep your revision
Yes.
implants here? And do you think the cup and the stem is ingrown?
Yes. So here, the anti-protrusor cage has been used.
No,
And,
it's a normal
vestibular
hemispherical cup.
fixation.
Normal cup.
It's a
Yeah.
normal cup. Two
Yes.
plates are there. And the normal cup is held by 2 or 3 screws, and it's a Zimmer stem. So we
Right.
should know the implant actually.
Yes, always we should know the implant, so that sometimes you might have to change the head. So that needs to be know that which
Absolutely,
implant is being
absolutely, yeah,
used.
absolutely.
Anup,
Because-
can you, should we look into the spine problem?
Yeah, we should have spine x-rays that every total hip case, be it primary revision, we should look at the spine. But
No,
this
no.
patient's spine was all right, because if the spine starts getting fused, there are instances where the hip will start dislocating. You are right, we should look at the spine. Yes. But in this case, the spine was okay. It's a post-traumatic case. Now, here is the importance of looking at the implant stickers or finding out what the implant was. This was the conventional poly and a 36 metal head. As Dr. Bhende rightly pointed out, it's a metal head 36 with conventional poly. You can see the posterior wall or lip has broken, and that was the reason for the hip dislocating and him becoming a recurrent dislocator. So that's very important. We should have ready revision sets, but once we know that the implants are ingrown, something has gone wrong with the articulation. And simple solution is to change it to a ceramic head and a highly cross-linked poly. That's what it did. We changed the ceramic head, and for that you need to know the implants. So you ask for the ceramic heads of that particular company and X3 poly, and since last 1.5 years, the patient has remained stable.
I
So
think
this is a counterintuitive case, just the first introduction to what kind of instability patterns we see these days. Any comments, or we should go on to the next case?
Anup, can I?
Yes, please.
Anup,
Yes, sir.
most patients are not going to keep stickers. Most surgeons are not going to keep stickers.
That's right.
Have a registry in place. You
That's
just
right.
write to registry and they will send you the important what stickers, what the patient has.
Provided the surgeon had registered that case in the registry, the
No,
problem
I'm just
in our,
telling you, when
yeah.
you have 98 or 100% registry.
Yeah, absolutely, sir. We should thank you for that effort.
Yeah.
And we put all our cases in the registry, you know that. So it's important.
I'm just giving you some information that if
Absolutely.
you don't
Another suggestion is for the taper, because I think you need to really look into that also when you are using
Correct. Dr. Dave, you made a great point. We should look at the taper, and if there is trunnianosis, then you need to use a sleeve on which you put the ceramic head. You don't have a sleeve and there is severe trunnianosis, grade 3, 4, then you have no option but to revise the stem. Yeah, absolutely. Yeah.
Okay, can we, next case?
Yeah, we go on to the next case. We are going into a further pattern of instability, which will be more severe. So 75-year-old patient with history of bilateral total knee 2 years back had a subtrochanteric fracture and was operated like this and went into non-union. He's 75 years and you can see there is implant failure and fracture non-union. We are not discussing really why the implant has failed and what better fixation method could have chosen. But at this point of time, with this kind of fracture, 75 years of age, broken implant, there is no option but to go for a total hip. So we went for a total hip, got the trochanter back, use a Wagner stem, 32 head, the cup size was 48, and the patient was doing well. And after about 3 months post this surgery, he presented with a dislocation. And we put him back. He reduced in a single attempt, and on table, when we are reducing, we should see what is the direction of instability. Is he stable? Are there any signs of implant loosening? All those things the surgeon has to see himself under C-arm. It's absolutely crucial that once we have a dislocator, we should analyze everything under the C-arm, whether the hip is stable or not, direction of instability, and so on. Then we put him back, and the implant was stable. It has not subsided. We can discuss subsidence in great detail maybe some other time, but we have to look at the subsidence of the stem, because if the stem is subsided, then it's loose probably. That can be another cause of instability. And it dislocated again. Now let me stop here and let me take some other faculty members into the loop. And Dr. Avatar, what do you think? is going on. He is dislocated twice. It's a 32 head. What do you think is the problem?
Dr. Noop, I will always choose a dual mobility cup when I am treating this kind of a patient because they're old.
Great point. Great point. Brilliant point.
They're old and they have undergone a surgery earlier. So they have a lot more chances of dislocation.
Absolutely. There is abductor deficiency. There is soft tissue, 75 years. Dr. Pachore was mentioning these patients are at higher risk of dislocation. Surely, in current scenario, dual mobility should be the primary articulation in this particular case. Dimple, right. What would you do now? He's dislocated 3 times. And you put him back, it comes out again 3 times. What are you going to do now?
So you rightly mentioned the trochanter, there is no non-union, so abductors are not functioning well. So what I will do is both the things. We'll revise the cup and put a dual mobility cup, and at the same time we'll make the trochanter in a such a way that the abductors are little tight. So I'll bring the trochanter down and refix it.
So yes, why would you change the cup? Why would you change the cup? Why can't you just put a dual mobility liner in this particular cup? Why change the cup?
So if you can put the dual mobility liner, then it's okay. I mean, there is nothing wrong in it.
That's right.
It depends on the cup which.
Absolutely. So this is a striker cup which has a dual mobility liner available. Yeah. So you can go for a dual mobility.
Yes.
Yeah. So we revised it, and you can see we put a dual mobility, and we checked the position of the stem, checked the position of the cup, ensured that the stem was not loose, and it had, by this time it was almost 6 months and the stem was solid, and we refixed the trochanter. We can choose a trochanteric plate in these cases, but as you can see that the soft tissues are not that good, and if you put a big plate, then the chances of infection and impingement are also there. Plus, it adds cost to it. Anyway, we put a dual. Yeah. Yes.
Just one comment. We don't need to do anything with the trochanter. We don't need to put any plate because we have a very thick stem distally. So it's not possible to put a plate, and you don't need to do that.
That's right. That's right.
Atit, you want to give a comment?
Yes, sir. Sir, it was good that we could have put a dual mobility cup inside, but supposedly a dual mobility was not available. We can first try for a constrained liner in this if dual mobility. So this is striker and a dual mobility. That's right. But in other systems, you can do a constrained liner because both stem and cup is fixed well. We are not worried about them loosening with a constrained liner.
I agree with you, but then you should have a constrained liner of that particular site in that system, or you had to cement it in.
Yes, yes.
I agree. We'll come to that. We are coming to that.
Yes.
The story is not over yet. Oh. Dr. Pachore, he was stable for next 3 odd months. So now it's 9 months from now, and he came with a dislocation of dual mobility. Now let me take Dr. Pachore here. So Dr. Pachore, dual mobility is not a panacea for preventing instability. How often have you seen dislocation of dual mobility?
Yeah, this only one case I have seen. This is my own case, which I did a proximal femur, something like this, multiple operated case, and I did dual mobility. Starting with LPS, and I reconstructed whatever abductor I had, and that lady, in spite of everything version, she dislocated, and finally I had to put a constraint liner for that patient.
Correct.
These patients, one important message, Anup.
Yes.
They have very high rate of dislocation. Reason
Absolutely.
Is multiple time operated, scar tissue, abductors are extremely poor. And Dr. Avatar was saying that refixation of trochanter is not important. It's a very important.
That's
because refixation of the trochanter, whether it is a fibrous union or bony union, that is one of the very important fact.
You have to tighten it up. That's right. I agree completely.
Whatever the technique you want, we have described one technique which is will be in publication in short time. But anyhow, that is that's a beside point. But very important is that and Anup, you have kept the cup transfer. Still, this dislocates.
Yes.
So very important message that there is something going on with abductor. So it's possibility that is the reason this dislocates.
Right. That's right.
It's a bald trochanter almost.
So we did look at the possibility of getting the trochanter down with a plate and or a small trochanteric clock kind of a situation, but the trochanter was so osteoporotic, it was 75 years patient, and we could not succeed with that. So now, Dr. Pachore, he's dislocated a dual mobility. Can you reduce this closed?
Usually,
No,
closed
no, no.
is very difficult.
No.
Very difficult. But you can keep an option on the table that tell the patient that I will try flush close reduction. If it doesn't, then I will open it up. Most of the time, it is what I did was I could not reduce that patient, which my patient was. That's the only one I had.
That's right.
And there is something soft tissue which is also there behind. I think calcified, something which are marked.
Yeah. So we have to look at various.
CT for this patient.
Sorry, somebody is speaking. Yes, please.
Dr. Avatar wants to say something.
Yeah, I had 2 of these dislocations and it was not possible to do close reduction. So I had to do open reduction in both the patients.
That's right. So I think the message we are giving to all our listeners is dual mobility is not a panacea. We need to look at all causes of instability.
Absolutely.
The head size, the orientation, the inclination, the version, the abductors, everything we need to be looking at. Now, we were thinking and what we should do now. So I thought that this was a cause. Anterior impingement is also a cause for instability. So when we reduced this, we looked at this big anterior piece, and there was a big anterior piece of the trochanter, the lesser trochanter, which we thought was impinging in when the patient was going in flexion. So we excised all of that. Once we put it back, we increased the head size by 1. So we increased the head size by 1, made it more taut, and excised that anterior piece that you can't see now.
Yeah.
So we excised that, thinking that this was an impingement issue, and did everything by increasing one head size up. But truth behold, dislocated it again. Truth behold. So now let me be here. Sorry, I went ahead. Okay, so he dislocated again. Now let me come to Dr. Bhende. Now it dislocated dual mobility 2 times. We have excised the anterior bone. We have taught, we have increased one head size up. What do you think we should be doing now, Dr. Bhende, to make him stable? Now, total of about 6-7 dislocations, 3 with the larger head and 2 with the dual mobility. 6 total dislocations. Yeah.
Anup, the one most important dictum of treating any dislocating hip THR is to find the cause of dislocation.
Absolutely.
Commonest time, the surgeon goes ahead with the surgery and saying, "Abhi operate karke dekhenge kaise hota hai." That doesn't work. Unless you are convinced that X is a cause. Now, cause could be mechanical cause, like a mal component alignment. And I presume you have checked that your version of a head, neck, and version of the cup is right. So, presuming that it is right, then the other cause is a biological cause, which is a weakness of the abductor mechanism. And abductor mechanism is the only, I think, single most important factor in controlling dislocating hip.
Absolutely.
So, if you have already undergone patient who has got a fracture of the trochanter and somebody has put a nail, that nail is 16 millimeter big drill, which is drilled through the proximal part of the trochanter to put that interlocking nail, you have to put that much big drill. So that means the trochanter and abductor must have been shattered at the time of the primary surgery treatment. Then we have undergone at least 2-3 times by doing open reduction. So the only thing I can suggest is if mechanically, if everything is right, your offset neck length, anteversion inclination is okay. Then you repair the abductor, you take those trochanter, osteotomize the trochanter at the level where it is attached, distalize that, and keep the patient in slight amount of abduction and in a plaster boot derotation bar for about 6 to 8 weeks. I've done it 2-3 times. Patient don't like it to be in plaster boot derotation bar. You feel it is a very archaic solution because we have never done that in the recent thing because we want the patient to be standing.
We did that abduction pillow for 6 weeks every time.
It's a boot and bar. The pillow doesn't work. The patient keep on moving. You have to have that amount of fibrosis happening.
No, I'm not talking of the pillow. No, Dr. Bhende, I'm not talking of pillow. There is
boot
a
and bar,
brace with straps on both the legs, so it's fixed in abduction.
So what I'll do is I'll osteotomize the trochanter and try to distalize it to make sure that on table I get adequate abductor tension and wire it up together, because wiring is the only option which is there. You can't put any kind of a plate because the plate will not have any distal hold.
That's right.
And keep the patient in abducted position and a position of stability. It could be interrotation, it could be neutral based on your intra picture, and keep him there for at least 6 to 8 weeks.
Right.
And
So,
that probably will work.
Dimple Bhai wants to say something. He
yes,
had raised
Dimple,
the finger.
please.
Yeah.
Yes.
Yeah, so what Dr. Hari said, which is very right, to bring the trochanter down and anteriorize if it is possible.
Right.
That is one thing. And second thing, what we do a lot of tumor processes for the tumor cases. So what we do is we use a hernia mesh. So what we can do is use a hernia mesh.
The chances of infection. So I have done a lot of oncological surgery, but that increases the chances of infection actually.
But then we don't have any option. I mean, we don't want to dislocate and
No.
reoperate over
That's
a period
right.
of time.
So what would you do now? We have done all of this except the mesh. So what is the option now? We have done everything that was explained in past few minutes.
Anup,
Yes,
we have heard you, I think, in the past about this gluteus maximus flap.
That's right. It's very good, but in this particular elderly patients, the mass is already been operated so many times, but we do Gmax flap, and you can take anterior and posterior flap and enhance your abductor function. But that is usually in cases where you lose your abductor completely because of metallosis, trunnianosis, or heterotopic ossification. But we did not do that in this particular case because this case is about 2 years old now. But we do abductor, we do Gmax flaps more often now.
Yes, Dr. Pachore.
Anup,
Yes.
you have done everything. Only thing is pre-op CT of this patient to know the version and the now option. What Bende says is not going to work because this is 3 times operated. Abductors are completely scarred. Getting trochanter into position is not going to be possible. The only option remains is a constrained liner, but I don't know the long-term results of these constrained liners.
Correct. So let's go ahead with this.
Sir,
Yes,
there is a question regarding this. Is there any role of adductor muscle release or an obturator neurotomy to counter the abductor weakness?
No. There is no role. Yeah. So we had this option, this was last option. We really had our back against the wall. We have to make this patient stable because the biggest thing is the faith of the patient. So he has come to us for a bilateral TKR, the hip fracture, then a total hip, and after 6 dislocations, he's still coming to say, please give me a solution. So, that faith encourages you to go for the last solution now. And we've seen, you can see the cup is nicely antiverted, the stem is fixed, everything we have done. The only option we have to now is to put a constrained liner. Now, the caveat here is that this cup is 48. And this particular system, the constrained liner starts from a 50 outer diameter. So if you have a larger cup, you can cement a constrained liner. That's the easiest option. But that we could not do because the constrained liner was bigger than the cup. So we had no option but to take the cup out. Now, to take a well-fixed, ingrown cup out in a 75-year-old man is not a great idea, but we had to do it. And the second challenge here, Dr. Pachore and Dr. Bende would agree with me that the explant system of Zimmer is great option. But when we used a dual mobility liner and we don't have a poly, we can't put the explant system in. So we tried to put in a poly and use explant initially, but then we had to use very meticulously sharp osteotomes, curved osteotomes, 5 millimeter, 10 millimeters. Took about 45 minutes to take the cup out. And finally, we put in a cemented constrained liner, and now he is finally stable for last 1 year now. But this was the various shades of gray or various shades of instability that we took from less constrained to a dual mobility to a constrained, and this is the way we handle this particular case. Now we can take critical comments from the faculty.
Parin, your voice is not coming. Yes, speak.
Unmute, please.
Can I, sir?
Parin, yes. Parin, you are not applied your that earphone. That's why we are not getting. No, it's not connected.
Yes, Dr. Pachore.
Anup, you can use an explant system on this. Use a bipolar poly, whatever the size is, and you put it and do it.
Yeah, yes. we did that, sir. But what happens is when you use the poly and it's not a fixed poly.
It moves.
So it moves. That's about what is happening because the poly moves and the explant moves. So it was not very effective.
Dr. Anup,
Yeah.
There is a audience feedback is there. Audience feedback is there.
Yes.
When initially there was a non-union of that patient at the age of 75,
Yes.
why not to use Hemi rather than a THR? The recent papers are coming that Hemi and THR results are same.
No, not at all. Not at all. This patient is very active. Otherwise, he has at least 10 to 15 years of longevity, no comorbidities. That's why he could take so much surgery. He's very active patient.
No. Initial first surgery.
Yes,
that is the
yes.
question.
Total hip will give far more pain relief in long term. If the patient's longevity is 5 years, 4 years, maybe you can use the bipolar.
Yes, Parin, can you speak now?
Yeah, the same question, sir. Cup was fine, so why not a bipolar? Because 75, if 10 years also, we can do the second surgery instead of so many surgeries.
Yeah, so Australian registry data shows clearly in elderly patients the dislocation with bipolars is higher than total hips. Elderly patients.
Okay.
But sir, because we want the biggest head to go, sir. That is the biggest head we can put in.
That's right. But in bipolars, you do not have that much control of your offset and version. So that's why the dislocation of bipolars in these cases is higher.
Anup, we need to move to the next case. Naveen bhai.
Yes,
Can we move forward? I think because
yes, you can move forward. There are not.
Thank you very much for elaborating the cases of instability and the different type of options available to solve the problem, including the constant liner.
Who is the next? Start sharing the screen. Who is the next one? Please start the screen.
Dimple.
Yeah, please start the screen. Share the screen.
Dimple, your
Yes,
case.
to stop the sharing screen.
Yeah, it will automatically. It will get. You share the screen. It will go continue. So there is a time. So I can ask questions. There are questions.
Yeah, you can ask, but Dimple, start putting your screen.
Yeah. He can.
Can I ask one question? Hello.
Yes, you can ask the question.
To Dr. Anup, is that any role of EMG NCV after first dislocation to know the status of the abductors? Because it is said if abductors are totally gone, then the concern is a better choice than dual mobility.
No, abductors are non-gone. The abductor, the tension is not there because of non-union of the trochanter. So I agree, initially we should have used dual mobility, but this case was done about 2.5 years back. So now we know that these cases first choice dual mobility, no question. But the thing is that dual mobility also dislocated in this particular case. And then we increased our head size, reduced impingement, everything we did, and still it dislocated. So, these are some cases, very rare cases, but these are cases which give us important lessons.
Just one comment about this.
Yes, Avtar.
If we get a high offset stem during first surgery along with dual mobility, that can reduce the chances of dislocation. That will increase the horizontal offset. That will cut down the chances of dislocation.
Yeah, so Dr. Avtar, this was a Wagner.
Yeah, that's the problem with Wagner actually. We don't have a high offset in that. But if we have a high offset stem, modular stem with distal fixation, I think that will solve the problem.
But sir, Wagner has already higher offset than the normal stems.
No, it doesn't have. It doesn't have high offset.
Yes,
Then
Dr.
the trochanter which we are going to fix it is going to have a higher, it is going to lateralize it and distalize it.
That's right. That's what we did after we revised the dual mobility. We got it down, fixed it with the holes in the Wagner, got it down, used Ethibond also, and tried to, hold it there. But it's still, it was still happening.
So you tried your best and she tried her best.
He tried his best.
Whatever.
But fortunately, last we got him right. But it was a big ride. It was a tough ride.
Thank you very much. Thanks for an excellent guidance on the instability. Dimple, can we move to your case, please?
Yeah, sure. So this is the case which we do it routinely, post-traumatic arthritis.
Dimple, your voice is cutting. If you required, I will stop your video only, your face only.
Yeah, that's fine.
Is it okay? Okay.
Yeah, perfect. So it's a 75-year-old male patient, post-traumatic arthritis, and we know this case coming very regularly. And we do a medial bone grafting, and ultimately it heals well. And after 6-month follow-up, you can see very nicely medial wall which is reconstructed. So this is a routine case, but now we have encountered one case, which was a 73-year-old patient, acute trauma, central fracture dislocation. You can see on the CT scan, there is a medial wall which has been affected, not much anterior and posterior wall. And there are the other films of the CT scan. So now what is the options which are available? So whether we go for, because the age was higher, patient was not very active. So what are the different options that we can do?
Can you go back to the X-ray?
Sure.
Hello?
Yes.
Yeah. So, sir, in this X-ray, is ischial line is intact, but iliopectineal line is gone. So mostly it's an anterior column injury.
Yes,
So,
along with this, it was anterior column.
And so an anterior column take away the quadrilateral plate. So pelvis acetabulum might be oblong acetabulum, not a hemispherical acetabulum because of the anterior column injury. Right. So need to put graft or some augment to construct the anterior column.
Okay, right. I agree with you. Any other suggestion from anybody?
Yeah, and Dimple, we should not operate these patients very early on. We should allow some kind of fibrous bony union to happen, because if you operate them very early on for a total hip at least, this can be fixed also by a pelvic-acetabular surgeon and should be done. If it is not done, then we should wait for some time before we go for a total hip.
Dr. Avtar, your comment on this?
No, I agree with Dr. Anoop that we should not do them in acute phase. We should actually fix them initially, or if we don't fix them initially, then wait for a couple of weeks and then take on.
So how much long should we wait? That was the main the message I want to give to the audience.
I would wait
3 weeks or 6 weeks.
I would wait 6
6
months.
months.
Yes, that's
Minimum
the
4
idea.
to 6 months.
Yeah.
6 months.
Yeah.
So the issue is if we keep them in bed or if we do not mobilize them early, then the chances of elderly patient, the other issues would come up. And
yes, Dr. Pachore, your comment?
You can't wait. You can't pick the patient six months in the bed. Out of question today.
Yes.
The patient will die. So you have to fix them. If you can't, you have to fix them. Today we have an excellent pelvic-acetabular surgeon in the country across. So you are not confident. You ask your colleague to get it and get the anterior column fixed. And if comes for arthritic, then you already constructed wall, and then you go ahead and do a surgery.
So we have got a Karthik who does it on a regular basis. Once you fix it, how long will keep you in the bed?
No. Once you fix, you don't have to keep them.
You can mobilize
mobilizing them.
Yes.
Yeah.
Then you can mobilize this patient. Not weight bearing. At least you can start sitting, side learning, get on the walker.
Maybe 3 weeks. That not more than that.
Yeah.
So he was not very kind of a person who would walk non-weight bearing. So at least we have to wait for 3 to 6 weeks. That is the thing which needs to be done, right? So unfortunately, this patient came after the primary surgeon did was a hip replacement surgery. And what
after how many weeks?
Immediately. It was done immediately.
Oh, immediately. Oh, yeah.
And you can see there is a bone graft which was done medially. And he kept the patient in the bed for 3 weeks. And when the patient came for the follow-up after the removal of stitches, you can see that this is the situation.
That's right.
Yeah. So the message for me to give to the audience is to don't do immediate hip replacement surgery. So that is one thing. By any chance, if you want to do it, by any chance, which is not a good advice, but yes, Dr. Sanjay sir.
I just want to summarize the whole thing. Basically, these are very common geriatric injuries, and most of the pelvic-vestibular surgeons fix them. Medius and anterior, there is a seagull sign. You have to restore the articular surface, fix them, and then. But in case you don't have access to any pelvic-vestibular surgeon, and you don't want to do a vestibular surgery, at least put them on traction for 3 to 6 weeks, so that the whole thing comes out. There is consolidation of the medial wall, and later you can plan a total hip subsequently, as said, 6 months or whatever.
So very rightly said.
So
at
these
least
are very
we
common
should wait.
factors to be fixed with earlier.
Yes. So by any chance, if you don't have, ideally we should wait for 6 weeks. That is absolutely necessary. But if you want to do it, what I would suggest is, I mean, this is not a good idea, but still, either you can use a multi-hole cup, which is again chances of failure is very high, and then only option remains is a entry protrusio cage if really you want to do it, because then you might have a good fixation inferiorly, superiorly, and then you can use. This is what we did it once the patient came to us after 3 weeks. Somebody referred to us, and then we did entry protrusio cage, put a lot of bone graft on the bone bank, because we didn't had head right now. So we put the bone graft from the bone bank, and then which was fixed. And then you can see a 1 year follow-up, the bone was consolidated and the patient did well.
Yeah.
Just one.
Yeah.
Yes, Dimple.
Yeah, no. Any questions or
Yeah,
any?
I think that's an excellent message to everybody. As Sanjay said, this is a very common injury occurring in the geriatric people. A lot of us see the fracture acetabulum, and we are tempted that, oh, let's not do weight and let's do a hip replacement. But it's always, everybody has said, always better to wait or otherwise do the fixation. Yes, Atit.
Dimple bhai, you have done a protusio cage and a cemented cup. So
Yes.
what do you think? How much will this last?
I mean, he's a 73 years old patient, not very active, sort of housebound. I mean, he was just going for a social visit to the things. So that was the only option which was available, because all the medial wall, anterior wall, which was not probably was there.
Right.
So maybe 5-7 years or 8 years.
Okay.
Yes,
Yeah, can I make a comment?
Yeah, please.
Yeah.
Yes. So if we analyze this X-ray, Dimple has done a good job. Ideally, the ischial flange should go in the ischium. Sometimes that will not be possible, because if the ischial flange does not go in the ischium, then there are high chances of its loosening out. But Dimple has done a good thing by putting an inferior screw, because otherwise the chances of the cage coming out loose are higher. And the third more important thing is that when you put your cage, go for the best fit. You don't have to look for the anti-version or the inclination. You have to get the great fit, and you have to adjust your version and inclination in the cemented cup.
Yes.
Prateet was saying, to get stability.
Navin, any questions from the audience?
Yes. There are questions for the previous case.
Yeah.
One.
Okay, you want to complete, Dimple bhai? You complete, please.
Can I ask a question?
Somebody else is calling.
We will use change over time. Yeah.
Can I ask a question?
Dr. Sanjay wants to say something, and Dr. Karthik then, I think.
No, I just want to ask the question from experts here. Suppose this was the case once after the dislocation of the cup. If there is posterior wall deficiency, there is medial wall deficiency, and it's a very wide, completely dissociated cup. Is there any role of two-stage surgeries, like you do a primary grafting there, fill up the whole thing, and then do a cemented liner, and then just temporary, maybe 6 weeks?
Sanjay, Sanjay, Vijay Bose has already written on this. It's offloading. So you just in the first stage put the cup and don't put the stem.
Yeah,
Even if you are thinking that you are not going to mobilize the patient after the surgery, they say that even in the bed also there is going to be some forces working. So in one of our case, when we took his advice, he said, do two-stage, put the cup, don't put the stem, wait, let it consolidate. In the second stage, do the stem.
Yeah, but that's not possible in this case, because the stem is already there.
Stem is already there.
Yeah, stem is already there.
So you can't do that in this case. You have to go for a definitive solution in this particular case.
Can I ask a question?
Yes,
please.
One question to Dimple. That is there any place for a modern non-cemented cup and cage system, which I have been doing since last 3-4 years?
Yes. Frankly speaking, I don't have much experience on that, because I'm not using it I mean, I've not used it anytime.
Okay.
So I've used this cupcake system since long. So I was more confident doing this.
Uh,
Okay. there is a question for the previous one. Dr. Anup,
Yes.
one trauma surgeon has said that
Yes.
your non-union of subtrochanteric possibility of osteosynthesis was there rather than a replacement. Just a comment.
Yeah, that's right. That's what we said. That
There
we
was a
can discuss
possibility.
that.
He has said
Yeah.
the possibility. The head was viable. So
Yeah.
that comment is that after replacement there are so many problems. Why to not salvage that head?
Because we have a large series of these kind of fractures.
Okay,
And
okay,
elderly
okay. This
patients
is just comment. Just a
yeah, I
comment.
know. We can discuss that in detail, but in this
And
particular
another question is, after you use the constraint liner, what the longevity you are expecting from that case?
That's right. So there are two good series of one is by Charlie Yang and the other there is another series of elderly patients cemented constraint liner. There is a 75% survivorship at 8 years. 75% survivorship at 8 years. So considering this patient is 75, we are looking at 10 odd years, I hope, yes.
Dr. Pachore, your comment, and then we move to the next case, please.
Avatar was talking to, this is just for information for everyone. This is one of the good system available, which is an uncemented cage. And you have option of turning out anti-version and all that. That's one good thing which is already in our country. So if anybody wants to use, he can use it.
Dr. Pachore, that Peter Brown, I think Peter.
Same.
Peter Brown.
The Peter Brown.
Available now, I think it's not very easy to get hold of that.
No, it is easier. I'm thankful to Avatar also because he just showed one case and I came and did one.
Yes, Sanjay, let's move to your case, please.
Yeah, good afternoon, everyone, and thank you, Deepak Bhai and Navin Bhai, for allowing me. This is a 49-year-old male who was operated with some hybrid THA 10 years ago, maybe more. He had an infected implant which was removed around 8 to 10 years back. Now, for 8 years, he was walking with his limp and shortening. He had almost 5 centimeters shortening, and now he started getting hip pain. Maybe more efficiency was needed. Hip aspiration was done. It was negative. He was very insistent on getting his hip replaced and getting a better gait. So we thought of it. So there was no evidence of infection for last so many years. So this is his what we got the pre-op. So you can see there's an old cemented sleeve, cement sleeve you can see in the proximal femur. The conventional stem being used. Trochanter is malunited and there is deformity of the proximal femur. So unfortunately, he had some vascular problems. He is a known case of ischemia, but it was not very bad for us to proceed. We did his CT. I have more. Yeah, I'll go. So problems with it were that the acetabulum is shallow. There were no landmarks. Tried to identify teardrop under C-arm, ischial tuberosity clinically. Luckily, medial wall was good thickness. Medialization done. I'll show you the CT. Good circumferential cover of the cup was available, but it was very shallow. So you can see the CT. The posterior wall is shallow. But there is a good medial buttress of bone which is seen. And then cement was in the femur, and it was a good cement sleeve. It is not something we could have avoided. Greater trochanter was deformed, significantly widened and malunited, and there was very significant overriding. So this case is more for my learning also. We have proceeded with the surgery. If you want, I can share the post-op later. So there are multiple problems: shallow cup, overriding cup, not good landmarks, femur cement sleeve, and then deformed proximal femur and a very malunited trochanter. So I would, if you want, I can wait now or I can show you the post-op X-ray.
I think wait, Sanjay, Harish Bhai, we have not heard you. So just want your comment on the femur side. What problems you encounter and expect? Would you do the osteotomy?
My only worry is the patient has an infected THR and the primary THR is removed without the cement mantle being removed. I can see the cement mantle in the femoral stem, and it is possible that some infection may still be there. I am a little worried during these cases if the entire cement is not out in a primary case when this implant has to be removed. So depending on these parameters, I would prefer some time to go back, remove the cement, take deep cultures, wait for some time, and then a second stage, go for a definitive surgery. That's number one. Now, presuming that there is no infection and the cement mantle is removed, then usually we can have a properly a distal part of the shaft is quite adequate. There is no significant deformity below the level of lesser trochanter. So any good distal fixing implant should work well. Only thing is the entry point, the trochanter is healed into varus position. So for access to the entry point, I may have to do trochanteric osteotomy by choice, not for approach, but more for getting proper access to the center of the femoral shaft. So during the approach of this hip opening, I will do trochanteric osteotomy as a choice, get the trochanter out, access the proximal part of the femur, remove whatever is cement, etc. is there, and then I can use any distally fixing standard femoral stem and reattach the trochanter after the entire THR is done. So that's regarding the trochanteric part. Now regarding the
I think
regarding the
so basically the issues here for a surgeon would means how if you need to do a trochanteric osteotomy plus you need to do an ETO and you might need to do
no. We don't need to do ETO. You can do a trochanteric osteotomy which is little longer, not entirely going down to the base of the shaft. So you can get trochanteric osteotomy which is little longer, going up to that level. You can see the triangle, that noted thing.
Harish bhai, just 1 minute. Anup, can you do without ETO by just extending the trochanteric osteotomy?
That's
is ETO
right.
must in this case?
The objective is to remove the cement. So we can do till the thicker part of the cement plug, we can do it proximally. We don't need to come down. And from whatever is opened, we can remove that final cement plug. But more important than that, the basic thing is we need to know the organism with which this patient was infected initially. That's very important. If the patient had E. coli or something like that, then that will change the equation.
And for 8 to 10 years, patient was completely asymptomatic, walking though with limp, but he had no signs of infection. We did an aspiration of the hip a couple of times, but all came negative. And ASR, other CRPs were negative for quite significant number of times.
Considering that patient is not infected, then we need to come down, remove that cement plug, choose a Wagner type of a stem with all those points that Dr. Bhende mentioned, removing the trochanter in your way, getting the entry straight, and then carefully getting a small cup into that shallow socket.
Yes, Dr. Pachore.
I agree with Anup. If this patient had E. coli before, I would leave it to somebody else. I would not touch this patient because
I had one such case which
I burned my fingers. Even though their ESR is normal, everything is normal, and such a patient aspiration is not possible. It is a false idea.
Yes, Karthik Shukla, we have not heard from you. Any comment on this?
Definitely, sir. I do favor ETO or a long trochanteric osteotomy for 2-3 things. Number one, I would like to use the Sinova Sure kit as well. Apart from the culture, definitely for sure. But before doing implantation, we have an idea whether there is infection or not. So that is one good thing we can add.
That part has been cleared now. There is no infection. We just want to see the approach of the femur. Would you be doing?
I would like to do for a osteotomy for sure. It will help me 2 things. It will definitely, as Dr. Bhende has rightly mentioned, the cement. We need to remove the cement very well. It can be a culprit. So there should be a thorough irrigation and cleaning of the canal, and it will help us that the entry point will be more precise and the trochanter will come to better position.
Sanjay, can we move forward? Sanjay. Navin bhai,
Sanjay bhai.
Probably he is lost.
You're lost.
His video is lost, so.
His video is lost. Let me stop his video so that he can come by the sound at least. Dr. Sanjay Dar, you lost your internet connection probably. Will you allow me to control your computer, so that I can move forward one slide?
Do we need to call him?
Or we can take this case later on. Somebody take over.
Somebody can call him.
No, calling will not serve purpose.
The next case
we
can
take the next case. We take the next case, and he will come back again. I think it's just
So
I'm
stopping
connection.
I'm stopping his sharing. Who will be taking? Please take over. Take over.
Yes, Atit Sharma.
Yes, sir.
Yeah, please put on your.
Oh yes. His screen is freezed. His screen is freezed.
Do we need to call him?
We need to call him. At least he has to, or I have to remove him. He has to join again.
Yeah, you can do that.
Let us wait. Just let me call.
Because his screen is freezed. He's not. It's not allowing me to stop his screen sharing. I am trying to stop his screen. Yeah, but I have to remove him. Yeah. Okay. So somewhere TV is running. Okay, now share the screen. Next person. Yeah, please.
Yeah.
मैं ना आधे घंटे बाद होना मैंने फोन ना करो.
Yes, sir. Good afternoon.
Mute karo.
Good afternoon, everybody.
Yes.
So THR introduce you. I'll go through the history fast. So it's a 43-year-old male, and he's tall due to gigantism, difficulty in walking, both hips more on the left, and he was operated for left acetabular fracture 2 times. Once the plate was put in, and the second time it was removed. That was before 4 years. So just to give an idea of the height, this was his height, about 6.97 feet. All the blood parameters normal, and this was the X-ray. So we will be looking at the left side of the pelvis, the left hip. This was the CT scan, and you can see there's bone on both sides, protrusion on both sides, but there is good bone on the medial aspect. So this is the X-ray, the left side, and just to give you the dimensions, these are the dimensions measured on. It's about 10.3 centimeters of the acetabulum, and the canal also is about 31, 32. So let me start with Pachore sir. Sir, what are our options here?
Yeah, these measurement may not be right,
right.
Because you have to have a CT measurement. These are wrong measurements.
Right.
That is one important another thing. And look, osteoporosis is high for this patient, and acromegaly. These are known cases for severe osteoporosis. So I think the approach is going to be a total hip. There's no question about it. And certain precautions you have to keep in dislocating. Go on gradual releasing capsule, rectus, whatever is possible, and try to mobilize the hip as much as possible. But you have to see pre-operative itself after anesthesia how much movement patient has. If there's no much movement, I think straight way for a neck osteotomy like an ankylosed hip, and then take out a piecemeal of that bone, whatever is available, only mouth rib. And most important fact of this is Ranawat dictum. Medial grafting, absolutely. Center of rotation normal, and use a stable cup. So these, if you look at the very carefully of this, there is a full wall is calcified, so there is no dissociation. So these patients will do well with morcellized impacted graft. There's a technique of reverse reaming and so many things, and use a multi-hole cup, get the normal center of rotation, whatever the best possible is. And femur, you have to be extremely careful because of this osteoporosis. So you need a multi-hole cup for this patient. You may not need anti-protusive cage, but once in a while you have to keep on the table if required. That should be your approach.
Okay. Sir.
Anup, you think expect any major defect problem in the acetabulum?
No, because this is a type 2-3 protrusio, and as Dr. Pachore said, we have to get the center of rotation right, and this measurement, our cup takes purchase between the anterior and posterior column.
Yes.
So this is not the accurate measurement, it's the column purchase, and though it will take a bigger cup, but it won't be this size, obviously. And of course, I would like to see my SIAM also once my trial is in. Multi-hole, at least 3 good screws pointing towards the sacroiliac joint. And stem we haven't discussed. So stem, I would like to use a primary stem, but be very, very careful that the calcar may crack, and check under the C-arm once the whole surgery is done that we haven't caused any fractures.
Dr. Avtar, you think that with this size of acetabulum which is seen on X-ray, you will be able to get away with the largest jumbo cup available, or you think you will need something else? No, he's not there. Navin.
That too with difficulty. So we must have the option of cage also on the table, but I think we can get away with the largest cup, multi-hole cup, and with bone graft in the acetabulum.
Yes, Atit, can move forward.
Can I make a comment?
Yes.
Yeah. Number one is, in these cases, which is a very large cup, we are talking about impaction grafting with the help of fossilized bone from the femur head. The one most important point we have to remember when you do this is, if you want to replace a non-cemented cup on this, the cup must have at least 20, 30, 40% of peripheral fit. Because if you have entire cavity filled up with a morselized bone, and on the bone you put a non-cemented cup, that cup will never get bone incorporated. So in such cases, if you have got a largest cup, which is maybe 68 or 70 millimeter, and on this, suppose it is more than that, then I would just do impaction grafting, maybe put a cage on that, and then put a cemented cup on this. I'll be scared to put just a non-cemented cup with a significant amount of impaction grafting, which will have some kind of a barrier between the host bone and my cup rough area. So there has to be at least
the impaction grafting only for the floor, not for the walls or the columns.
Yeah. So we have to make sure that your cup is peripherally sitting on an actual host bone and there is no graft there.
Yeah. Yes, Atit, let us move forward, please.
Okay, sir. We did a 3D model of the acetabulum just to find out what exactly would be the size. So this is what it is. Testing is 66. By the way, Dr. Kartik Patel was there in the surgery with me. So this was a 66 cup, and we saw that there may be an augment which would be required during the surgery.
Atit, wait. Anup,
yes, sir.
How useful is this modeling, the 3D models?
It is pretty useful and accurate, but then you can ream on it and put your cup like this, as he has shown, and yes, they are pretty accurate if you can get them. Yeah.
All right. Any comment, Dr. Pachore?
No, this is very useful. We have been using this, and it's very easy to get it. Just within 3 or 4 days, you should be able to get it. You have to just upload your CT scans with soft tissues. That's all, nothing more.
And even the cost is not that very high.
No, cost is not that much.
Yeah. Yes, Atit, move forward, please.
Okay. So, sir, our planning, we were able to get cup size up to 70. That was T-Mars Gription and Wagner stem 23 highest and 16 Corel and femoral head grafts. And we had also kept SROM and Reef ready. So this was our plan A, T-Mars with augment and a Wagner cone. The second was a cup cage construct and a Wagner cone. And plan C was SROM or Reef.
Wait. Avtar, which will be your planning in this, A, B, C?
I'll go in for with the Wagner and the T-Mars Cup. That will be again my first plan, and probably that will take me through.
Yes, Atit, move forward, please.
Yes. So we did a bone grafting, a T-Mars 70 and a Wagner 23, and we fixed it with about 5 screws all through, and a lot of bone graft behind. And first we got a good hold at 21 Wagner, but then when we saw on IITV the angulation was not proper, and so then we put a 23 Wagner inside. So this was our final X-ray.
Wait, Anup, your comment on this X-ray post-op.
Yeah, so cup looks all right. So there are 2 options, either to use a larger cup or use a cup and augment. In these primary situations where the bone quality, at least of the column, is good, we can do with a bigger cup. I didn't think an augment would be necessary. And this is, although I would have chosen little longer screws, but that's a minor thing. I'm a little concerned about the length of the stem because this is the smallest 167 stem. And it's a 22-167, right?
23. Yes. Yes.
23-167. Yeah.
Yes.
So otherwise the construct looks all right, but I'm a little concerned about the size of the stem and the length of the stem.
Harish bhai, your comment, please.
Yeah, number one, this is what I was talking about, that the amount of bone grafting which you have put inside, which appear to be covering the entire cup, at least on the AP picture, there is no contact of the periphery of your cup to the host bone.
Right.
Presume that you have got a good contact at the anterior and posterior wall, and if that is the case, probably the cup will work. But if there is entire thing is covered by the bone graft, this cup eventually over next 2 years is going to become loose. Number two, that osteoporotic bone, if you can see, the cortical index is very high. I mean, the medullary cavity is too big and cortex are too thin. I would be probably putting maybe cemented stem. There is nothing wrong in putting a good, nice cemented stem in this case, because non-cemented stem with such a osteoporotic bone may not work very well. It may become loose, and you are using 23, which is one of the largest stem they have.
Dr. Pachore, the suggestion for the cemented stem for the femur is well taken. What would you have done for the cup side?
I'm not too happy on this. This may not be stable, what Harish says.
Now, what would be the option? Suppose you think that, as Anup earlier said, probably the augment would have been a better option.
Either augment or use a cage. That's a unloading the whole thing.
Okay.
Yes, Atit, move forward, please.
Yes, sir. This was the post-op X-ray. The opposite side we had done before this, so as to have the head for bone graft. So this was the post-op X-ray, and these are the two X-rays. One is at 15-day follow-up, and the other is at a 2-month follow-up.
Karthik Shukla, any comment?
Karthik was operating surgeon with him, so probably he's knowing the case.
Karthik Patel was operating. Karthik Shukla.
Okay. Karthik Shukla is joined. Okay. He has kept himself mute. I have to unmute him, I think. Yes. Okay, Karthik bhai. Your voice is not coming because your that is not there. Your mic is not working, sir. You are not attached that with the mobile. Yes. Now it has come.
Okay.
Go ahead.
I also agree with Dr.
There is another device you are opened up, so we are getting echo. Is there any device you opened up, mobile, other browser?
Meanwhile, Anup, you can have your comment, please.
Yeah, Atit, can you go back 2 slides to the immediate post-op?
Yes, sir.
Yeah, okay. Now come back to the 2-month follow-up, please.
That X-ray we can't see clearly, actually. The 2-month follow-up X-ray is not visible.
Yes,
on the left side.
So we have to keep our fingers crossed and see how this patient does on a long-term follow-up.
Atit, my question to you, in the way of modeling, you showed very beautifully that augment sitting on the cup. Why did not you use that at that time on table?
So this was in the model, it was a 66 cup, but this is a 70 cup. And when we tried to put an augment there, we had to remove some extra bone to fit in the augment. And so we thought that we would not do it. The anterior posterior fit was good enough, so we did not do the augment.
Yes, I think the primary aim is to get the solid fixation of the cup. The augment does not give us the solid fixation of the cup, may actually prevent so. In a primary situation, this is not a revision situation. So if he has got solid AP fixation, that's good enough. That's good enough.
Dr. Dimpleby and Dr. Bhende wants to say something. Dr. Dimpleby, please.
Now, the augment would be on superior wall. It won't have an anterior posterior. So it will have a better fixation. So if we probably would have used, because Dr. Bhinde is rightly saying that if the graft is all around, the fixation will not be that good. So you can have a less bone graft, superior augment, and then anterior posterior purchase would be an ideal thing, probably.
The CT scan modeling which you did showed that the cup to be 66, and now post-op X-ray, when you have put 70 cup, which is much bigger than that, it is still looking much smaller with respect to the actual acetabular X-ray, you know. So either the CT scan model was grossly wrong, and that's why your planning didn't go very well, because there is a huge discrepancy between how well that CT scan was sitting. Can you go back to the CT scan?
Yes, sir.
3D picture. Can you go back to that?
See,
Yeah. Now
sir,
that is
3D
fitting.
picture
Yeah, that
here.
3D CT scan is fitting very well, if you can see. And then if you are seeing the cup, if you see vertical position, I'm not saying AP, but vertical position, your 66 cup is sitting actually flush with the superior cortex. That means, but on post-op X-ray, there is a huge gap between the two. That means the CT scan judge, the dimension probably were not right, and that may have misled you.
So, can I comment?
Yeah.
Yeah. So, second picture of the 3D printing, it suggests that it's a whole big void in the medially. So, if we put the cup inside, there was no hole of the 66 cup. So, if we so this helps us to how much to lateralize the 66 cup, and so at what point of lateralization we can get the anteroposterior contact of the primary cup. After lateralizing that, we have void on superiorly, which can be filled with either bone graft or augment. But on table, rimming to expose the wall, the osteophytes, you can see the osteophytes on the anterior wall in second picture, all removed. So in 66 cup had no hole. So we put the 70 cup, and with the 70 cup, we get the minimal gap superiorly, which filled with the bone graft.
Okay. I think Atit, just move forward.
Yes, sir.
We still have 3 more cases.
Okay, sir.
Dr. Sanjay has joined now.
Yeah.
We can take up his case in between if you want.
I'll stop the share now.
Yeah.
I think I think a good discussion on this acetabular defect, bone grafting alone to get a good purchase, what type of cup to use, modeling, use of the modeling, the augment. So, and don't forget that there is still a role for cemented stem, as Dr. Pachor and Dr. Bandem mentioned. It is possible in osteoporotic femurs, not a bad idea to use a cemented stem. So I think it's a good case. Let's move forward, Parin.
Sir. This case I have opened up already. Sanjay Dar's case.
I think
he has joined.
We need to move from where we left. Sanjay, so I think we about the trochanteric osteotomy, ETO, removal of cement to rule out the infection. All these things were discussed in the previous session. Can you move forward, please?
Basically, this case was put up for both.
Sorry?
Yeah, so Dr. Navin has to move it.
I will move it. Ischemic disease, you said. Now there is a CT scan.
Yeah, we have discussed this. We have discussed the femoral part.
Okay.
Yeah, you go forward.
Okay, acetabular part. Should I go forward?
No, forward.
So, no, basically, this case was put for both acetabular difficulties as well as.
Okay, go ahead.
Yeah, so there was a good cement sleeve which could not. What was attempted was here. The only mistake I made, as Dr. Harish said, that you should have done the osteotomy first, which I did the last, in fact. So we tried to save because it was a deformed trochanter. So we thought of doing the osteotomy last if needed. But since we could not remove the cement sleeve from the top, so we had to do osteotomy. But even then we could not. It was a very well fixed cement, which was probably 10, 12 years old. So we did an ETO. Hello.
Yeah, here's the post-op.
Yeah. So after the ETO, once the cement was removed, we tried trial reduction, but we could not get the hip down. We had already done the acetabular cup fixation, this acetabular trial. So we thought of doing a femoral osteotomy because the trochanter was also malunited. So to correct the version of the trochanter, we tried to do femoral osteotomy. We did an osteotomy, and then we could put a Wagner stem. And since the acetabulum we had a good bone stock in the acetabulum, we could put a good well-fixed cup there. And so, but only problem now was the trochanter was not coming down since once we reduced the whole thing. So you can see here not a good fixation of the trochanter. So my questions basically are that in case of something like a developmental dysplasia or even very high, and probably Dr. Harish is speaking on that, excision hips, where you need to do a femoral osteotomy. So how do you do an ETO? How do you do an trochanteric osteotomy in such cases? Because cement, if you can't remove the plug, to do a long stem is very difficult. And besides, what about the malunited trochanter? If it is version is not good, so you cannot get a good version. So with the rotation of the femoral osteotomy, how much can we correct? So all these questions are there. So it's open for discussion. This patient is now 6 weeks post-op. He's walking with a walker, but I'm always worried about the trochanteric wires. It might break. And although we have got a reasonably good X-ray, but about his long-term results, I want to discuss that.
Dr. Pachore, what he's saying that after doing the ETO, he removed the cement and then he realized that he cannot reduce it. So at that time he had to do the femoral osteotomy. Do you think he would have thought of this before at the time of planning?
Which I have never done this. What he says, a double trochanter osteotomy, ATO plus subtrochanteric shortening is too much to a soft tissue handling. Because very rarely you need for excision hip to do a subtrochanteric, but it is well described that you sometimes once in a while you need a subtrochanteric osteotomy. There is no question. Normally I do it because there is a malunited trochanter. If I am planning for extended osteotomy, I would not detach the trochanter. So if required, I get a small window at the level of the wherever there is a little plug available. And a lot of windows I have done this, and then you can take out the cement and drill through that. And then if you require a subtrochanteric, you can do, because you are keeping a soft tissue intact quite a lot. This malunited trochanter can impinge and can cause some problems, so we have to be a little careful of high rate of dislocation of these patients.
Anup, your
Dr. Avtar has raised the finger.
I agree with Dr. Pachore. We don't need to need ETO. We just need a smaller window distal to the cement, and then we need to use high-speed burr from the top as well as from through the window. So we can easily take out the cement and then use the standard Wagner.
Yes, Anup.
This is not a subtrochanteric osteotomy. This is a transfemoral osteotomy. It's far below where a classical subtrochanteric will be. But I'm sure Dr. Dhar was stuck because he could not reduce it. And then he extended the distal part of the osteotomy to make a transfemoral osteotomy. So we have had such one case only. And this transfemoral osteotomy helps you remove the cement and get the whole thing down. So very difficult case actually, this one.
Harish bhai, your comment?
Yeah, I had mentioned in the beginning that you take a osteotomy of a trochanter as an approach and bring it little down, not a small trochanteric, but going down almost to the lesser trochanter, which would have been much easier to remove. Only thing is, if you make a long distal transfemoral osteotomy and it goes below the isthmus level, then you do not have a very good fixation of your long stem, because your canal is trumpeting open. And then sometimes we end up putting a very large amount of distal non-cemented stem, which also can become little unstable. So you have to be very careful. Second thing, regarding getting the trochanter down, the only thing you can do is to release the trochanteric abductor soft tissue from inside and remove the fibrous tissue without damaging the muscle. It is not a very easy thing, but it may allow the trochanter to come down by maybe 1 or 1.5 centimeter further. But
is there any role of iliac release from the iliac? But that may be
I don't think you should do it, because then your muscle will come in your hand. You release it from iliac crest, so that is technically a free muscle coming. On other side is a free trochanter. Proximal attachment is gone. That muscle may slough off completely. So I'll be very scared to do an iliac crest release.
Yeah, I think Sanjay, it's a good case to demonstrate the problem.
Other question. Just one question. Other question is, which stem should you go ahead? I have used a Wagner here, which has the maneuverability to rotate the version. But is there a better, maybe a SROM or any other prosthesis you could think of where you have a malunited trochanter?
Solution or epsilon?
I think
Dr.
Wagner
Anup wants
is
to
good.
say
Yeah.
something.
No, SROM gives you actually fixation proximally more than distally. So I don't think this is a good case for SROM. Dysplasias are great cases for SROM, but Wagner is the best term for this particular case.
Okay, I think. Jore, would you think of cement in this case?
No. This was old infected, no question.
Okay, fine. I think, Sanjay, let's move further because we are running out of time.
Thank you.
Farin, can you just put your case now, please?
Yeah.
Hello.
Yes.
Am I audible?
Yeah, you are audible. Your screen is seen. Go ahead with the opening the PowerPoint.
Good afternoon, everyone. I think this is an very rare entity, but last 2 years we have treated around 4, and this is the recent one. So just to go through, this is the case of a lady operated THR around 10 to 12 weeks back elsewhere. She comes to me with pain in groin. It's excruciating pain. She can't stand up or come out of car, or she can't even turn in bed. So she comes to me almost crying, "Sir, why did I went to this surgery?" So at this point of time, 3 months down the line, sir, I would ask seniors, what are your thought process? History of fall trauma.
Farin, I think just little move forward because
these are the pre-op X-rays. So classical OA may be due to the FAI, and these are the recent X-rays.
Have you got the lateral views?
Yeah, sir. Last bit. This is a lateral, but
Not very clear.
Not very clear. So it's an.
What size of cup you have used?
The size of cup is 48, sir, and it is an MDM cup by Stryker. It's not done by me, but the stickers are available. 48, sir, not 45.
Who's writing all this thing? With
Navin, sir, I think.
Yeah, because we need to see the X-rays. So I'll request. Let's.
So you say the patient came with severe pain, difficulty in movements, 2.5 months down the line.
Yes.
With this
Yes, sir.
X-ray to you, correct?
Yes, sir.
Okay. And your question is what can be the cause of pain?
Yeah, so excruciating pain, sir, 2.5 months back, just 2.5 months of the surgery. No history of fall trauma, no any symptoms of infection, fever or anything, no discharge.
Can you tell the location of a pain and whether it is
exact groin pain, sir, groin pain.
No pain on the thigh.
Nothing, sir.
And the pain is on load bearing or even at rest.
Yeah, so that's all the active psoas muscles problem, like getting in and out of car, getting out of chair, getting out of bed. Once he starts walking, the pain is gone.
Okay.
So basically it is related to the flexion of the hip, correct?
Yeah, active psoas contractions. So I will go through it, sir, a bit ahead. So these are the X-rays pre-op. Sorry, it's going back. Some patient went to some other surgeon and asked for the knee pain. They were thinking the knee is the cause of the pain because she was.
Can we go back to the hip X-rays, because we need to analyze this? We don't have a good pelvis X-ray, but
pelvis with both hips, yeah.
Pelvis with both hips, and this cup looks as if the version is less. Yes. So this cup looks anti.
But sir, it's a dual mobility, so we can't judge. The metal liner will not allow.
This is a dual mobility. Stryker's dual mobility.
Yeah, MDM 48 size cup.
I'm talking of the cup.
We can still see the anti-version.
The cup is still, because you can't see both the margins, though this is not a great X-ray to judge that, but the cup has less version.
But do you think that will have a bearing on the pain?
That has got a significant bearing. It has a significant
bearing, because that means that the wall, the cup is exposed anteriorly, and if the cup is exposed anteriorly, then it can cause impingement. It can cause psoas issues also.
Sir, the psoas, if I have not told, but what were the thought process, sir? Directly you will jump to the psoas part, or you will rule out anything?
I'm just analyzing this X-ray. That's all.
Okay.
Can anybody see the medial cortex? There is a sclerosis somewhat at the attachment of the lesser trochanter part.
That's okay, sir. That might be the overlapping thing. So we went through infection markers, sir. That is the most, suppose subclinical infection is there. So C-reactive protein was 1.5, which is normal, and even procalcitonin was also normal. Even USG was done elsewhere, which was showing no effusion or anything. So patient, why she came to me was, she was advised teriparatide somewhere, and they just came to me, sir, whether we should buy these costly injections for this pain. So what I did, I just came through all these typical clinical signs. All patients, mostly they complain this: rising pain from a sitting position, climbing in or out of a car, which is called car sign. It was described by Jasani et al. Even she can't move the affected leg in bed. And sometimes the pain is with coughing and sneezing. Most all 4 patients came with same history, and they say, sir, the pain is same as before, maybe before the surgery, it's same. So what we did was, we just ordered a second USG, and typically telling the radiologist, please look at the psoas static as well as dynamic. So what, luckily she is my wife, so what she found is, this is the right side affected hip psoas, which is around 10 mm, and this is around 4 mm. So you can see the difference, and this is swollen and almost looking frayed. This is the normal one, normal tendon. So these are the classical signs and classical diagnosis for psoas impingement. I will just run through it. Mostly it is caused by the anterior overhang, which may be because of lateralized or oversized cup, sometimes because of retorted or a closed cup. Even nowadays, it is seen mostly in revision because of cement plugs, reconstruction cages, or the dual mobility cups. Because nowadays we are using this liner, which are very bigger in size. This is the study in Massachusetts, Boston, where they are trying to get contoured liner, although it's still not available here. So that's what they say. This conventional liner of the dual mobility even can cause impingement, even though your cup is normal in size. So what we did is, as non-surgical part, anti-inflammatory medications and physical therapy were given by other surgeons, although for some other cause. So what we went through is injection under USG. So it is diagnostic as well as therapeutic. This is the first video where we are reaching the psoas. And this is after infiltration into iliopsoas bursa. About 50 to 60% of the time, this is curative, one injections. Surgically, I have treated one case with the same incision posteriorly, but using half of the incision, and we released through the laser drop. So this is the lady, now post infiltration 3 weeks. She is very happy, can get up from bed, can walk. Mild urge is there. What they say is it will go in next 3 to 6 weeks. Just to summarize, this was I'm just running through. To summarize, even with proper placement of acetabular cup, we can have this psoas impingement due to the liner, or nowadays because of more active patients. So diagnosis is mostly fairly typical from the signs. Patient is comfortable while walking on flat surfaces. Infiltration is good diagnostic as well as therapeutic options, and surgical release through the same incision is easy to perform. Even though it's a complication, it is curable. That's what I can say. It's easily curable. Thank you.
Dr. Pachore, groin pain and the cause of psoas impingement, how frequently and commonly you can see or anticipate?
Frankly, I have not seen many of this patient. It's an overwritten entity. Second, importantly, it happens with dual mobility is a classical phenomena, and that's why the new dual mobility are coming, which is cut off inferiorly and anteriorly, because the cups are usually
below equator. They are decreasing the size, sir. Below equator.
Yeah. And what literature says that the larger size, what Harish was saying, the larger size cups have chances much more than the smaller size.
Even, sir, larger heads, the metal on metal heads were having more cases, 15 to 20% of the cases.
Yes, Avatar.
It was reported in the literature with earlier designs like carbol cup. It is mentioned in the literature, but once they changed the design of the cup, it's not a common phenomenon these days. But this is a new thing on the video today, that he's getting it with modern cups, but with the old.
Sir, maybe we are not able to bottom it out. Cups designs are fine, but sometimes the surgeon may not be.
Maybe we are ignorant about this.
Yeah.
Harish bhai, you think that ultimately, eventually, this patient may require revision of the cup?
If the pain is very severe and it doesn't go by the release of the ileopsoas or injection there, then the only option left is to revise.
Sir,
and I tell the patient many times, I have got only one such patient, which not my own, it was referred to me.
Sir, sorry to interrupt, but all studies say is, you can read it, psoas release is the best because the complications are more in the revision of acetabular component. Unless dislocating, you have to do only psoas release is enough. If it is dislocating with psoas impingement, you may have to revise the cup. Because this is the largest study, sir, of all psoas impingement, 30 patients, 29 they were treated with either local injections or release.
Farin, I think it's a good message about the dual mobility, as Dr. Pachore said, that you have to be careful about the positioning, the type of implant, and you have to put it in the right place. And options as discussed by all of us, the injection or the release. But it's a good case, and we have to keep in mind the type of pain specifically related to psoas activities. So I think it's a good case. Thank you very much. Let's move to the... Yes, yes, Anup.
Yes, so while the other presentation is coming, this also is a point against use of dual mobility in simple primary situations.
Yes.
Dual mobility is good for instability situations or potential unstable situations, but indiscriminate use of dual mobility is also not right.
Anup, I can see smile on Dr. Pachore's face. Karthik, your
Okay. Good afternoon, everyone. So my case is a THR in hip arthritis with the non-union of the acetabulum fracture. So this is the case, 51-year male, history of fall and right-sided community acetabulum fracture, presented at 4 months with the right hip pain and limping while walking, standing time less than 10 minutes, walking distance less than 15 meters, no fixed deformities, movements are painful and restricted, shortening around 2 centimeters and tender test was positive. So this is a pre-op X-ray. Suggestive of erosion of the femoral head with the superior acetabulum dome, superior medial defects, non-union of the fracture column, and the medialization of the inferior hemipelvis. So we did the CT scan. We first did the Juliet views to see the column anatomy better, like iliac view, which shows the posterior column, obturator view in the anterior column, and the inlet for the protrusion. So this is a CT scan, which clearly shows the non-union of the fracture with the medial protrusion and the defect superiorly and anterosuperiorly. And the 3D CT scan confirms and is more confirmed that the quadrilateral plate was more in continuation with the posterior column. So now option of the treatment to Dr. Harish Bende, sir.
Yeah, if it is an unstable and it is a non-healed fracture acetabulum involving both the columns, then there are question is, one is you can stabilize the posterior column with the help of posterior plate and use the head as a graft medially, and then you can use cup, which could be something like a revision cup, where you have got a peripheral screws as well as a screw going through the cup. Like you have got this revision cup from the debut, which has got a peripheral screw and a central screw. So if you want to do as a primary THR, you must make sure that you stabilize the posterior column by putting a posterior plate. So you need a good long Cocker Langenbeck incision, expose the non-union side on the posterior column, revise that thing, hold it together, use a proper buttress plate, then medially impact the graft as much as you can, and then you put a cup which is fitting. We normally use something like a gription cup. So you can do that in one stage, provided you are able to stabilize the hip. If you are not able to get a good stability of a hip joint, then I would do it in a 2-stage. First stage, you put just a grafting, stabilize the acetabulum, wait for that to heal, and then you can go back and do the regular hip replacement surgery.
Avatar, you think that we will be able to do it in one stage?
Yes, I think we can do that. We can again use that non-cemented cup and cage system just use a bigger size, distract the fracture, and then you can stabilize the fracture as well with the same cage. That will take screws in the lower fragment as well as in the upper fragment. And at the same time, we can put bone graft as well from the head.
Sir, Avtar sir, it's a pelvic dissociation.
Yeah, definitely. I have treated 2 such patients with the same technique. Bone grafting and primary distraction with that cup and cage.
To Pachore sir, can we stamp we as a pelvic discontinuity and treat as a pelvic discontinuity with the cup cage construct, or treat as a primary non-Indian? To Pachore sir.
No, okay. I think on the table you see how much is the frank non-union, because a lot of these patients have a fibrous type, and if they are not very unstable, I have done multiple times. I have done a grafting in just a multi-hole cup for many of patients. But if there is a frank mobility, then I'm luckily I'm at a good center. I have a good trauma surgeon along with me. I ask them to do a posterior plating and just follow stage grafting and multi-hole cup. Any good porous cup is enough for patients.
Can you move?
Yes, sir. So these are the intra pictures. Deform the femoral head, the fracture line, posterior acetabulum fracture line seen, and we put the cuff in the posterior column fracture. And this is the short video. We put the K-wire to demonstrate the mobility of the fracture site. Fracture was quite mobile, and all fibrosis were removed with the cords and periosteum, and posterior column plating was done. First, stabilize the posterior column. So posterior column plating was done, and then acetabulum of the posterior column plating. We aimed the primary cup fit from superior to posterior inferior to better purchase of the primary stability. So this was the medial protrusion of the acetabulum. Medialized morcellus bone graft was put, reverse rim and compacted. So medial defect was filled with the bone graft. And cup was put. I didn't use any multi-hole cup. I put the cup in that way so that I can get the longest screw available. And this was the primary stability of cup after the insertion. And this is the post-op X-ray.
Yes, wait. Anup. What type of cup was this, Karthik?
This was a Duralock cup from Johnson & Johnson.
Anup, your choice for the cup?
I would choose a Gription revision type of a cup because it gives you multiple peripheral screw options. With a Duralock of 48 or 50, whatever, you just have 2 screw options.
Yeah.
And I would like to have a more porous cup with all peripheral screw options, especially with a pelvic discontinuity.
Yeah.
Had this been a united fracture, maybe a primary cup, but this is a pelvic discontinuity.
Yeah, I agree entirely. I agree entirely with Anup that number one, you have to plate it behind. There is no question of not plating it and trying to get just a fixation by using a bigger cup and expansion. That doesn't work. That cup is going to become loose. So you have to fix the posterior column quite well. And once you fix it well, then you can do a primary THR immediately, provided you have got a better cup. The Gription cup revision from Johnson, which has got a peripheral screw. So it is like an internal plate. You're putting 2 plates, one outside and one inside. And that spans the entire unstable pelvic area.
Okay.
Navin, any question from the audience? Navin?
Just a minute. There are questions. Let we use the changeover time to ask the question. Who is the next case? Take away the screen.
So this is a 4-month. Just finished. This is a 4-month post-op X-ray, and good consolidation, and that was the video. Patient is walking with the weight bearing.
Dr. Sanjay, any comment on this?
No, I think all of the, you have to ensure that there is no mobility of the column. So what I do is I put a sham screw in the ischial tuberosity and then try to move the whole column. If it is moving, then you have to fix it. So posterior fixation is mandatory in such cases if you are doing primary.
Yeah, by the time Dr. Harish Bende prepares the next case, the last case, comment from Dr. Pachore and some questions from Dr. Navin.
Yeah, the question. Okay, Pachore sir.
Sorry, sir.
Okay.
Only thing is that regarding cuff, that peripheral screws for these patients may not require, because we have done a large number of fractures. So what only thing is point against is this Duralock is a low profile, and it's better to use a high profile cup rather than you don't need peripheral screws, so much peripheral screws. What Dr. Anup and Dr. Bende was pointing out, use Pinnacle, use any other cuff which is a high profile. So you got more contact.
Agree, sir.
Okay.
Navin, any question?
Yeah, there is a question from Dr. Tejas Gandhi for Sanjay's case. Was there a possibility of cement on cement in that without removing the cement after cynovascular testing?
No, that was already spoken about.
Okay. Yes, there is also a general question. What is the choice of replacement in 55 years old patient with neck femur with ipsilateral post-polio residual paralysis? This is a general question without referring to any case.
Dr. Harish Bhai.
Yeah, basically, if it is a post-polio residual paralysis, we have to make sure what muscle groups are affected. If the hip muscle groups are intact, then the THR can be done. We can go for, because 55-year-old patient, ceramic on highly cross-linked poly with a non-cemented cup and non-cemented stem, presuming that anatomically the acetabulum and the femur is normal and the polio involvement is distal. Now, only issue is if the patient has got significant quadricep weakness and have a hand to knee gait, where patient is standing with a significant amount of hyperextension of the knee, in which case the hip will get a excessive anterior force. So the hip will get extended every time the patient tries to stand, because these people walk with a hyperextension of the knee and some extension of the hip. So if that is a gait he is going to get, then we have to be careful about checking our version and inclination. I would like to put little more inclination and little less version in this patient, and a large cup, whatever, large head, whatever is possible based on the size of my acetabular cup.
Okay, now the question is from Dr. Vinay Parasar for again Sanjay's case to Dr. Bhende. When you go to remove the cement mantle, would you choose to put the stimulant prophylactically and wait for the second stage?
Yeah, I would have done this case in 2 stages. Stage 1, I would have gone and removed the entire cement mantle. At that time, I probably could have done the trochanteric osteotomy and taken a deep culture. It is extremely important in a case of infected revision that you know the culture and the organism before you proceed with the implanting of the new implant. At that point of time, I normally put stimulant granules. There is no harm in doing it. But if I can culture any organism, I'll be happier, because accordingly I can plan my second stage.
Okay, again the question from Dr. Surat Purohit for the last case of the Karthik. What is the rate of heterotropic ossification when we do posterior column at the same sitting while doing the THR?
Yeah, there are chances of the heterotropic ossification, mostly when you damage the gluteus minimus. But in this case, we need the posterior column stabilization anyway. So better to start endocap, endomethacin postoperatively for a few months. But there are chances in post-acetabulum fracture THR.
He wants the opinion from all the faculties, experience of all the faculties.
Posterior approach, copper leg and approach already has a very high rate of heterotopic ossification. So with THR as well as posterior fixation, chances are quite high.
So in this patient, the last patient, I would not like to put any kind of indomethacin or any anti-heterotopic treatment, because you have to realize there is a non-union of the acetabulum. If you don't fix acetabulum and it doesn't heal, then you are in a bigger trouble. I wouldn't mind having little heterotopic ossification at a cost of healing of my columns, which is primarily important. So I wouldn't take any care, because I want that columns to heal first.
Dr. Dave?
Yes, Anup, your comment, and then we move to the next last case.
The rate of HO in post-acetabular fractures, even if you have is Bruker only grade 1 or grade 2, which is not troublesome. Unlike in ankylosing spondylitis, Dr. Pachore's cases initially, which can be Bruker 3 and 4, which can be troublesome. So we don't need to do anything extra for post-acetabular fractures.
Okay. Thank you. I think Dr. Bende, your
Yeah,
case of the
sure.
Yeah, I agree.
Okay, we are talking about a technical consideration for THR in an excision hip. Now, excision hip is done for many reasons, commonest being infection, when we remove either the previous implant or there is a primary hip infection. But there are sometimes other reasons to do excision, like a badly damaged acetabulum or a badly damaged femoral head. Now, this is a one example of excision hip done for infection 7-8 years down the line. We treated that with a cemented component, THR, both sides cemented. Another case like this, again, almost 11 years after the primary case, he had undergone 3-4 surgeries. We had replaced that with the help of a non-cemented stem and a cup. We had to do subtrochanteric osteotomy here to relieve the pressure on the sciatic nerve because we had to do a lot of lengthening. Third case like this, again, abduction osteotomy done for some old trauma and excision hip done. This was a THR done, both side. It's a hybrid, cemented stem and a non-cemented cup, again with a subtrochanteric osteotomy. So basically, if you want to do excision hip for conversion, there are certain things which must remember. And the first and the foremost important is to rule out any infection or a presence of infection. Second thing is assess the amount of bone loss in femur and acetabulum. Assess if you need a lengthening required and how much you will need it. And if you need a special implant, because if there are bones are lost from femur and acetabulum, you need a bigger implant. Now, only one statement before I begin the actual case. A lot of things are described about finding out whether the infection is there or not, like finding out the ASR, CRP, aspiration of the hip, gram staining, osteolytic area, etc. But basic point is there is no 100% accurate way to confirm that there is no presence of infection. We have to do our best, but then there is still a small chance that during the surgery, you may find something out of the place, and you should be willing to stop at that point, take the deep culture and come out and do the hip at the second time. So don't feel shy and tell the patient beforehand that when I do the surgery, during surgery, if I find a pocket of pus or some abnormal tissue, I may not just go ahead with the actual surgery, and we may do it as a intermittent, second stage surgery. Now, this is a very interesting case. A 44-year-old female, she had a fractured acetabulum, and which was actually missed because of there are other associated injuries. Now, she was treated for the other injuries, and she was allowed to go home walking. And 6 months down the line, she started getting significant pain in the hip. And she went back to the primary surgeon, and he took a CT scan. You can see that there was a acetabulum fracture of a posterior column, and the hip has subluxed. You can actually see the amount of subluxation. You can see that there is a true acetabulum over here, and this is a posterior wall which is broken and a posterior column which is partly damaged. So the surgeon advised the patient, okay, we'll do hip replacement surgery for the patient. So they opened the hip, they started going for the surgery, and I don't know exactly what happened, but I saw the note saying that surgeon tried to put the acetabular cup, they tried to rim, but no size of a cup was fitting very well. So they could not fit the cup properly. It was always loose. So they abandoned the surgery. So by this time, they had removed the neck of the femur. And now this is how the patient had when they came to me. This patient then continued to walk like that on a walker, like an excision hip. And about 1.5 years down the line, that is 2 years from her primary trauma, she came to us. And this is how I inherited the patient. Now, if you take, we took another CT scan, and if you can see the CT scan here, this is the current CT scan. And you can see that the posterior column which was there is completely gone. The head of the femur is gone. And you can see this picture over here on your right side. And you can see that the surgeon probably has tried to rim into the false acetabulum. And when you do that, you do not have any hold behind, because there is no wall behind, and that is the reason maybe he was not able to put any cup. So this is how my cup was, and this is how she was at the end of the surgery. Now the question is, what should I do during the operation? So should I take any questions from the faculty? Anybody want to comment? We have time for questions from the faculty. or any comment from the faculty? Deepak bhai?
You can ask. You mentioned whom do you want to ask, sir?
No. Anybody want to comment on what would they do? How will be their approach to this patient and what they would like to do?
Dimple bhai wants to say something.
So basically, posterior column, the wall is affected, the column is not there, and already false reaming has been done. So it's very difficult to fix the acetabulum. In that situation, probably we'll have to go little inferior and put a small cup and fix it with a multiple screw, or we might have to reconstruct the posterior wall. That would be another option.
You think there is a role for 3D modeling in this?
Yeah, there definitely 3D modeling is a good option. It tells you in a 3-dimensional way, but it is not always necessary, number one, and two, it is not always available to everybody. I mean, in the bigger cities, you may have 3D modeling available, but if you are from a smaller town, it may not be so easy. But it is important to analyze the CT scan, and that's what I wanted to show in this patient.
Infromedial. You think we should be able to get the whole
infromedial? No, it is the other way around. So let me take it further. Now,
Sanjay wants to say something.
Yes, Sanjay.
No, there's a significant posterior wall deficiency. So you have to factor in, you have to keep allografts ready, you have to keep Gription cup ready, maybe a posterior wall cage, or maybe do it in 2 stages, do a posterior wall enhancement with a graft, and then hold it with
the allograft.
Yeah. And then secondarily do a proper cup. So maybe enhance the posterior wall first and then do a second stage cup.
That's a possible option. Definitely, yes. Yeah.
So we can reconstruct the posterior wall and column with trabecular metal and then do the cup.
That's true. You can use a trabecular metal because that's a new thing which can give you a significant amount of stability behind, and although at little cost, but it can work. Yes. So
another solution can be reconstruct that, and over that you put a cup and cage system.
Yeah, so you use the trabecular metal wedge or augment, and then you create a posterior support and then put your cup either a non-cemented or cemented. That's correct. That is definitely an option which is possible. Now, if you analyze the CT scan here, you have to find out what inclination and medial depth you want to get. So if you see the normal side of this CT scan, this is the acetabular cup which would have fit on a normal side. If you revert the size on the opposite side, this is how your cup should be on the affected side. But if you take this cup slightly at a higher position and allow the cup to migrate superiorly and not inferiorly, as Dimple has mentioned, because you get more bone superiorly than inferiorly. So if you allow the cup to be, placed maybe a centimeter at a higher position, you can get much better bone for your cup. And you need to also do 2 things. Number one, you have to downsize the cup, and you have to medialize the cup by reaming gently medially. If you see the AP alignment, the transverse section, this is the plane of a coronal plane. And in this coronal plane, this is your normal version. So this is the version of your normal cup. So I presume that on the affected side also, I need a same version. And if I try to put my cup in the normal version on this, I have got a huge defect on the back of my femur. And this is where we are talking about how to fill the defect. One option is use a graft. Number 2, second option is use a trabecular metal. Definitely can be done. But these come at a cost because graft may not heal very well and it may fail. And trabecular metal come at a cost again, and that may not always work very well. So what we normally do, although we keep trabecular metal option as a standby, we try to downsize the cup, make a cup which is smaller and deepen it by about a couple of millimeters deliberately. It's called acquired medial protrusio. And you can see that automatically your posterior support of the column becomes more now. And as far as you have got 70% bone contact on the posterior side, your cup is quite stable. You do not need any additional augment to be put over there. So what we tried to do was we downsize the cup. We deliberately kept the cup superior, almost about a centimeter, and we rimmed in a superior portion, which is like as Dr. Vijay Bose has mentioned, you try to seek the good bone. You put the cup where the good bone is. And by going superiorly, you are looking for a good bone of a host, in a host bone, and you can put almost like a primary cup over there. So this is the post-op X-ray. We can see that we have got a medialized cup. The cup has gone slightly superior, and we could get a primary cup without any additional augment. We had used a gription cup because it has got a better scratch fit, and we have used two screws as an additional fixation device. This is almost about 7 to 8 years post-surgery, and the patient is doing very well. Now, if you notice, we have used a cemented stem because this lady has not walked for a long time, and because of which her bones were very osteoporotic. If you go on the pre-surgery X-ray, there is a significant amount of cancellization of the cortex you can see in a proximal femur. So we tried to start with non-cemented stem, but it was not very stable. And then we converted that to a cemented stem because that is where you can get a very good fit and very good fixation. A lot of time I see that people are apprehensive about using a cemented cup, and I don't think you should be apprehensive about cemented stem because cement actually work quite well if you do it well, and we have a lot of cases of cemented cup. So that's how the surgery went, and in nutshell, we have to think about soft tissue problem like scarring, fibrosis, adductor tightness. We have to think about bony problem like loss of calcar, loss of femoral neck, loss of wall, etc. And if you plan everything well, then you can get a good operation. Before I close, I just one point. Many times, excision hip patients are very well adapted to their lifestyle. They are adapted to the shortening, adapted to the limitation, and they do not have much pain. They are able to walk very well. My suggestion is you should not try to convert these patients to THR because surgery is difficult, complication rate is very high. So unless the patient has got significant pain or symptoms of instability, you should not try to do a surgery for an excision hip just because the patient is there. Any questions?
Thank you very much. I think it's an excellent presentation about how to go about to rule out the infection and what are the precautions we need to take. We rightly said that not all the girdle stone patients are, they require the THR. You need to see the lifestyle and how they are adapted to the present condition. Dr. Pachore.
Oh, that's good. Harish, this small cup and medial wall has been, you know that it has been described first by Larry Dorr and one of the Chinese surgeon for dysplasia. So when you don't want to reconstruct too much of, I think it's a good option to do this, but we have to be extremely careful. As beginners, it's very difficult to do a medial osteotomy of the wall. So
can I? Yeah. No, number one, sir. Number one, there is no medial osteotomy done. We just keep reaming medially in a very gentle fashion. And we have to stop reaming when we can see medial 1/3 of the bone, which is reamed, because we have to keep peripheral 2/3 bone intact. And as I said, as you rightly mentioned, it requires a little bit of a skill and a care. Now, this technique is described first by a guy called Hartophilakidis. He's a Greek surgeon, because Greek people have got a lot of dysplastic cases in their country. And he probably described it maybe about 25 years ago. It's a very old paper. And they have mentioned about using this technique to allow using almost like a primary cup without using a big augment or a big amount of bone graft in their cases. But it works very well in excision hip.
Yes, Sanjay.
Yeah, so regarding this medialization of FUB, there is a technique where instead of
we lost his voice.
Yeah. Defect to break the floor, push it a little, and then the graft, and then you can go on as if you're creating an artificial protrusion. So you have a wall medially, so break the wall, medial wall.
Where is described? Where it is described? No. Where it is described?
The whole wall is pushed with a gravel graft like SLS plus.
Harish, it is well described by the Larry Dorr also, and as well as by the Chinese, one of the Chinese, I forgot her name, but it's a well described procedure. I will send you the paper later on.
Yeah, please, because trying to osteotomize is very difficult because osteotomizing can easily go more than what you need. The bone may crack more.
You do
And
multiple
yeah,
drilling, and the cup sides should be not very
Yeah,
small. It should be
the
yeah.
around
wall is just pushed
25.
medially. You create a segmental osteotomy.
Deepak bhai, there is a question. Can I run that question by? It is an
Sure.
audio file. Audio
Yeah,
file.
yeah.
Let me start it.
Sir, this is
Can you
Jigar
hear
Shah
it?
from Ahmedabad. There is a question to Anup sir and Mende sir both. So while we use multi-hole gription cup, so many times we end up with putting just 2 or 3 screws. So isn't it better to use just 2 or 3 hole gription cup so that we can have better surface area that comes in contact with the host bone, and we can get good incorporation of bone with the cup?
The answer is, when you have a difficult situation and you are not sure about where you will get the best screw placement, then it is always better to have cup which has got multiple options and then use whatever you need. When you use a cup which has got only 3 screw option, and you after putting the cup realize that those 3 options are not the best placement for my screw, then you are lost. I would rather have 10 options and then use 3 of them, or rather have than having just 3 option of screw and then realizing after putting the cup that, oh my god, among the 3, 2 I can't put in. So these are the cases not on a routine basis. Only when acetabulum is bad, then we try to use these multi-hole cup or a revision cup which allow us to give multiple options to put the screw.
Yes, Anup. Anup, you have lost your voice.
Yes,
No,
he
unmute,
has to
unmute. No,
unmute.
I made it. Go ahead.
Yeah.
Anup.
So in post-acetabular fractures, there is also rotation of the pelvis. So sometimes the inferior hemipelvis rotates in a malunion position. And that is when the gription revision cups really comes handy, because your original screws just don't find the right direction. And those are the cases you look at the obturator foramen. If there is rotation of the hemipelvis, then it's mandatory to use those cups.
Yeah.
Okay. There are questions are coming. If you want to discuss the case, then
I think we can take 2 questions and then it's almost 2 o'clock.
Okay. Dr. Bishnu has asked one question for this case probably. In this type of difficult cases, is there any role of accepting sort of the full stability of a non-cemented cup by allowing for bone growth with non-weight bearing?
No, the cup has to be stable and
Yeah.
100% fixed at the time you end the surgery. You cannot expect it will become better with the passage of time.
So there are 2 or 3 basic questions. One of the young orthopedic surgeon from Baroda, Dr. Arjun Nayak, who is a new member, he is asking about this Harding approach. What is the opinion about the Harding approach and the abductor problem?
Can I just talk? I actually have worked in England for 4 years, and during all 4 years, I have done nothing but Harding's approach. Before that, 5 years, I was a lecturer in Bombay, and we used to do only posterior approach because that's what we all do. 90% people used to do in Bombay. Then I went for 1 year fellowship with Ranawat. He does only posterior approach, but whenever it is required, he go by double approach. He goes from the front. Now I'm convinced that if you are just sticking to Harding's approach, it is good in 80 to 85% cases, but it doesn't address to 100% cases. I would rather use an approach which gives me ability to open any hip and put any kind of an implant with extensible approach, because Harding's cannot be extended distally, neither can extend it posteriorly.
Okay, again question from a young orthopedic surgeon, probably Dr. Parth Gawatre. He wants to understand the stepwise release of the soft tissue and bony procedure intra-op to get the head down against the cup. Please tell me in the detail. That is his question.
In what case? Is it a dysplasia case?
No, not in the case. He is the generalized asking the question. If I am stuck and head is not getting down, can you say me the stepwise soft tissue and bony procedure in short? Can you give a crisp message? It's a generalized question, I think.
Yeah, so I think first you need to look at your position. If your component is well positioned, your socket is well positioned, then you need to look at the stem. You haven't chosen a very high profile stem. So if you have that kind of a stem and then you find it difficult to reduce, then you have to look at your stem. Maybe choose a cemented stem and reduce. That's as far as the mechanical part is concerned. Regarding the soft tissues, the best is to release iliopsoas partially only, the tendon, and then try and get the hip down.
And the last option, osteotomy.
Right.
Yeah, that's in type 4 dysplasia.
Now who is sharing? Probably anybody is sharing,
No,
or we are ending?
I think we need to stop. I think at this time, let me thank GOA, the executive committee, all
Thank
the
you.
members
Thank you.
for
Thank you very much.
Thank you. Thank you very
and
much.
Writers of
Thank you.
CVR for sponsoring this program, the makers
So
of Program X.
if
So
you
once
want to
again,
know,
thank you everybody for
if you want to know the score, it is 4,354 at last. Highest score was 4,354.
And Dr. Thakkar, just parting shot, that since the lockdown is extended for 3 more weeks,
yes,
you can consider doing another of this, because I'm sure it's beneficial to everybody.
Okay. Now, Deepak bhai, your responsibility is increasing now.
Yeah, I'll be in touch with all of them and again take
Sure.
Again.
This time also I spoke to Dr. Thakkar, Dr. Bende, and got
let me tell you my experience of every webinar. Every webinar faculty says this, when we'll come with the second one. Ender's nail went for 4.5 hours. Then also they wanted a part 2. Katappa, they said that Katappa ko kisne mara, part 2, Mahabali.
I just want to say sorry if I have just cut short some of the speakers or the questions. The only reason, because I was knowing it's going to go a little further. It's already 2 o'clock now.
But it is a very good slow pace module, because every point gets covered, smaller points.
In fact, we were debating whether we should keep 10 cases or not. My both colleagues, Ronak and Yuvraj, they were saying, let us keep 5. But the whole idea was to cover little more subjects, more problems. So we thought, let's go. And you told me that we can probably...
That is always there in every conference module. Thode mein zyada chahiye.
Right. Thank you very much, and thank
you. Thank you on behalf of Gujarat Orthopedic Association.
Yeah.
Thank you.
I'm stopping the streaming. The streaming, and then you can have a 2-minute chat.